Good evening, everyone. Hope I'm audible. Hello, hello, hello. Perfect. So, audio, video, everything is clear. First, before starting the class today, let me clarify you people. So, in every YouTube videos which we have posted, hello, hello. So, in every video which we have posted, so in that description itself, usually you have the link for the notes. Okay. So, most of the video notes will be there from the link only. For this also at the end of the lecture, in the same link where you have this video description, there only you'll have the video lecture as well. Okay. Is that fine, Dr. Manish Dubey? And good evening. Hello. So, hi. All right. May हमेशा I do that. You don't have to even ask me that. My constant effort is to give you people that only that जितने भी क्वेश्चन आए वो हमसे हमारा जो शॉर्ट सेशन में डिस्कशन हो जाएगा वहीं से आने का कोशिश रखता हूँ मे बी सो देयर इज नो डाउट अबाउट इट जस्ट लेट मी चेक वंस ओके इंटरनेट इज कनेक्टेड ओके फाइन सो गुड इवनिंग एवरीवन तो चलिए शुरू करते हैं मेडिसिन राइट इन द मेडिसिन व्हाट वी आर गोइंग टू डू एंड व्हाट एग्जैक्टली इज इंपॉर्टेंट तो मैं आपको एक टेक्निक समझाता हूँ मेडिसिन में ठीक है मेडिसिन में ना आप लोग मतलब जितने भी पढ़ लो लाइक यू स्टडी हाउ मच एवर यू वांट ओके देयर इज अ प्रॉब्लम द प्रॉब्लम इज दैट सो इट इज मेडिसिन इज लाइक अ गेम ऑफ गैम्बलिंग मतलब यू नो इट इज द गैम्बलिंग ओनली ठीक है तो क्या हो जाता है यू स्टडीड एवरीथिंग एट द एंड ऑफ द डे whatever you studied so much but questions were asked in such a way that आप कभी सुने ही नहीं वो फिर भी it will be justified as medicine for you people तो इसीलिए इसको ओवरकम करने का कई तरीके तो वन ऑफ द टेक्निक इज टू ओवरकम इज वेरी सिंपल क्या करना चाहिए आपको हमेशा ऐसा फोकस रखो कि जो भी टॉपिक जहां पे एमसीक्यू आने का हाई प्रोबेबिलिटी हो वहां पे देखना चाहिए ठीक है तो हम पूरा पढ़ने का भी एक ही हो जाता और ये थोड़ा पढ़ने से भी एक ही हो जाएगा ठीक है so that is a target of learning medicine in a technical way okay don't worry I'll repeat everything in English as well okay now what we are going to do is that first we will start with the connective tissue disorders so connective tissue disorder is a large spectrum of diseases rheumatology बहुत बड़ा big chapter but in that I have concluded few topics which are asked very repeatedly and आप लोगों को एक प्रॉब्लम में होता है कि medicine like you know thinking that you'll study this arthritis from orthopedics medicine people will leave it out and medicine people like ortho people will think that medicine will teach them so they will leave it out at the end of the day you'll end up having difficulty so to overcome that let's start with the rheumatoid arthritis so rheumatoid arthritis from the rheumatology I have few diseases from the rheumatology which I want to teach you people so listen to me very carefully so when we're talking about rheumatoid arthritis, now listen to me, it's a very easy topic to understand as well. But the thing is that throughout the rheumatology, we don't know the complete cause. You get my point? So the main cause, the etiology is not clearly known. It is multifactorial. Matlab genetic factors will be there, and also immunological factors will be there, and idiopathic factors will be there. But whatever pathogenesis we know, we are going to learn. Okay. So the first disease I want to start with rheumatoid arthritis. So in the rheumatoid arthritis, many students have this one thinking. What is that? Rheumatoid arthritis as they study. So always they will think that what is it? Rheumatoid arthritis. बोलते ही immediately they start to think. Yes. I will do both. Do not worry about it. Okay. So rheumatoid arthritis. So that is हमेशा you'll think that morning stiffness is the only key. No, the morning stiffness is not only key, but also other things as well. Okay. So one second, I think there is some difficulty with this OneNote. Just let me check on that. Just let me reopen it. Okay. So in the rheumatoid arthritis, let's start with the pathogenesis. How does rheumatoid arthritis occur? Okay. So when we are talking about rheumatoid arthritis, the pathogenesis is very simple. यहाँ पे in pathogenesis we have two things. What is that? It is a response which occurs from the both T and B cell. The point one to be remembered is what T and B cell. Imagine कोई भी joint. Imagine any joint you want. In joint, when there is an activation or a response which comes from the T and B cells, so that will lead to inflammatory change. क्या होता है? What will do? Inflammatory changes. So what happens is that consider this is one bone, okay, and another bone is there. Now between these two bones there is a joint. In this joint there is an activation of T and B cells. Why exactly it occurs we don't know clearly. Very important point to be remembered. Okay, so now what is that? So what happens, both of them activate and they will start to damage the bone and the cartilage. Okay, so bone and cartilage agar damage ho jata hai to kya hoga? Now listen to me. And because of this T and B cell activation there is a formation of immune complexes. Formation of what? Immune complexes. Formation of what? Immune complexes. ठीक है, आपको क्या मिलेगा? Immune complexes will be seen. So that is why it comes under type 3 hypersensitivity. Type 3 hypersensitivity. Now maybe there is a immune complexes, and remember there is one grain like granuloma like structure formation. Directly remember the name of it. It is called as pannus. क्या होता है? Pannus. What is it called? Pannus. What is pannus? If I ask you people, remember pannus is like something like a rice grain, like a rice grain. Just it is more like a rice grain. We will get pannus, called as a pannus. Small grains will be formed. Okay. So the most important thing they are going to ask you is which gene predominantly plays a role. That is only called as HLA-DR4 gene. कौन सी जीन है? HLA-DR4 gene. Okay. Now what happens is that I have a patient with rheumatoid arthritis. Okay, rheumatoid arthritis can be associated with the other diseases. Can be associated with other diseases. Rheumatoid arthritis के साथ कई और diseases हो सकता है. Rheumatoid arthritis can be associated with a Sjogren's syndrome. What is Sjogren's syndrome? Come on. Sjogren's syndrome is an autoimmune. So remember one thing. Pura rheumatology, throughout the rheumatology, it is autoimmune is the word. Okay. So Sjogren's syndrome, autoimmune fibrosis of glands. कौन सी glands होते हैं? That is your salivary glands, that is your lacrimal glands in the eye, and bartholin glands in the female. So all these glands will undergo fibrosis. If fibrosis means salivary gland is fibrosed, fibrosis means there is no saliva production. Very good, you people are correct. That is dry eyes and dry mouth, also dry vagina in the females. Okay, so the patient will have dryness. The patient will have dry eye, okay, dry mouth, right? Dry mouth, and also it is common in female, that is dry vagina. Okay, so these are the three associated symptoms. Okay, it can associated with something called as Felty syndrome. What is Felty syndrome? Patient will have rheumatoid arthritis, along with that neutropenia. Neutropenia means decreased amount of neutrophils. Okay, so that is your Felty syndrome. There can be one more syndrome called as Kaplan syndrome. What is Kaplan syndrome? Kaplan syndrome is a rheumatoid arthritis along with the occupational diseases like pneumoconiosis. Simple, there are three diseases which can be associated with rheumatoid arthritis. One is Sjogren's, one is Felty syndrome in which neutropenia will be there, one is Kaplan syndrome where there will be pneumoconiosis. Clear? These are the points to be remembered. As there is a कैसे भी क्या होता है, point to be understood is that rheumatoid arthritis affect small joints. Okay. All right. Now, when you have a patient with rheumatoid arthritis, since it is affecting the small joints, right? Remember one important point: DIP, distal interphalangeal joints. This ones. This last joint होती है ना, distal interphalangeal joint. The last interphalangeal joint होता है ना, ये कभी भी this will never be involved. Remember this. What is it? This is never involved. DIP is spared. Okay. Now, rheumatoid arthritis patient will have morning stiffness. What is that? Morning stiffness. How long? More than 45 minutes. This is very important. Okay. Now, if you look here, my dear students, here you have a deformity. What is the name of this deformity? So you always do not bring mallet finger into deformity. Why I am telling you? Because you are going to get confused. See, mallet finger, exactly this is the deformity of mallet finger. Right? This is a deformity of mallet finger. Now, what I'm trying to tell you is that here in the mallet finger, only one finger is usually involved. In mallet finger, only one finger is usually involved due to EPL tendon damage. EPL tendon extensor pollicis longus damaged. What is that? Extensor pollicis longus is damaged. But here, if you notice, all the fingers are involved. Okay, if you look at this finger, wow, as if it is looking like a neck of a swan. Exactly. इसी को बोलते हो swan neck deformity. This is only called as swan neck deformity. Swan neck deformity. Swan neck deformity. Okay, so this is your, what is that, seropositive arthritis, that is your swan neck deformity, and this is a directly asked image based question multiple times. And the favorite deformity of the examiner is this one. Okay, what is happening, if you notice, all the fingers are going to a side. ध्यान से देखो, यहाँ पे कैमरा पे देखो, यहाँ पे देखो, all the fingers straight है ना. So now wherever my thumb is there, all of you can notice my thumb. Wherever thumb is there, thumb is what? Thumb is telling me what? Thumb is telling me that it is the side of radius. Okay, now this little finger is telling this side I have a bone called as ulna. So towards ulna, if fingers are getting deviated like this, okay, towards ulna, if fingers are getting deviated like this. So this deviation, if you can notice here, so this is a normal hand, and here you can notice to one side this is going. We call this as a ulnar deviation. इसी को बोलते हो ulnar deviation. Ulnar deviation. So ulnar deviation is seen with what? Ulnar deviation is also seen with rheumatoid arthritis. Rheumatoid arthritis. Okay. Now here also you have one more deformity. Here also you have, what is that? You have rheumatoid nodules in these joints. If you notice, sir, आपको कैसा पता चला? How do you know that there is a nodule? Now notice here, normally if you notice the joints, they're properly bending like this. But here in this female, if you notice very clearly, there is some swollen knots. So remember, यहाँ पे one more thing, DIP is never involved. Distal interphalangeal joint is spared. Distal interphalangeal joint is spared. But what exactly is involved here is that nodes formation called as rheumatoid nodules. So rheumatoid nodules. Rheumatoid nodules. Okay, so this is a story of your deformities. Okay, so what is the treatment for rheumatoid arthritis, my dear students? Treatment for rheumatoid arthritis is DMARDs. What is it? DMARDs, disease modifying anti-rheumatoid drugs. That includes drugs such as methotrexate. Okay, we have hydroxychloroquine, HCQ, hydroxychloroquine. Okay, then there is one more drug called as leflunomide. Okay, so these type of drugs are used. DMARDs, hydroxychloroquine, and leflunomide can be used. But along with that, most important main problem of the patient is what? Sir, मुझे दर्द होता है, उंगली में दर्द होता है. The दर्द का इलाज. What is the treatment for the pain? Pain treatment will be your NSAIDs. If patient is not able to tolerate NSAIDs, you are going to use steroids. So the story of rheumatoid arthritis is very simple. It is involving T cell and B cell both. Type 3 hypersensitivity. It is having a pannus formation, small granuloma types thing. So small granuloma types of swelling can be found within the joint. Okay. So allopurinol, we don't use it. Allopurinol is not used in rheumatoid arthritis. Rather, allopurinol is preferred in gout. Okay. Now the next point is that HLA-DR4. Okay, HLA-DR4. Remember, not DR3. HLA-DR4 is the gene. Okay. Now the next important aspect of what I'm trying to tell you people. So what exactly is that? This is a rheumatoid arthritis case. DMARDs are used. Okay. Now please listen to me very carefully. तो इतना ही तुम्हारा क्वेश्चन आता है, ठीक है? मेरा गेस, माय गेस इज दैट माय गेस गोस टुवर्ड्स दिस वन. अगर मुझे कोई पूछेगा सर आपका गेस कौन सी है, माय गेस इज अल्नार डिविएशन. ओके, क्वेश्चन आएगा तो डिफॉर्मिटीज के बारे में आएगा. ये रूमेटॉइड नोड्यूल्स वगैरह तुम्हें पहचानना मुश्किल होगा, बट दिस वन इजी होगा और आएगा भी, यही लगता है मुझे. ठीक है, चलो let's go to the next one. Osteoarthritis. What is this osteoarthritis? My dear students, remember all the things, all the arthritis can be two types. Serology of what? Rheumatoid factor, RA factor, rheumatoid factor. So serology in the serology you might have a RA factor. So in the serology, if positive, if a positive RA factor, we call it as a seropositive arthritis. We call it as a seropositive arthritis. If RA factor is negative, then we call it as a seronegative arthritis. So anywhere if I use term seropositive and negative, do not get confused. We are talking about the rheumatoid factor. So in the rheumatoid arthritis, it is a type of seropositive arthritis. Now osteoarthritis is a arthritis. It is a type of seronegative. It is a type of seronegative. Point number one. Point number two, this is a type of osteoarthritis, is a type of seronegative arthritis. And here the interesting story is that it is associated with the age. It is associated with the age and weight of the patient. Weight of the patient. What do I mean by this? So if at all you have a patient with the osteoarthritis, means the major risk factor. The major risk factor is what? Major risk factor is obesity. Major risk factor is obesity. And most importantly, remember in osteoarthritis, my dear students, it is such an interesting disorder. This is a very, very interesting and easy disorder. Weight pura, your body weight, most of the weight goes on to which bones? Automatically femur, and it will go on to the knee joint. So easily, because of the most of the time, involved joint is most commonly involved joint is knee joint. Then later it can lead to affection of the small joints. I agree with you people, but most important thing, most commonly involved होने वाली joint knee है, but it doesn't mean other joints are not involved. Other joints also can involve, but only thing you need to remember is major one is knee joint. Okay, let's continue. So it is a degenerative disorder. What do I mean by degenerative disorder? Degenerative disorder means if you consider this is a surface of one bone, this is a surface of one bone, and this is a surface of another bone. Now listen to me, between these two we have a cartilages, right? यहाँ पे क्या होता है, directly bone will get affected. It will destroy the bone itself. Okay, so what will be the complaint of the patient? So with the age, arthritis will be progressing. Progressive type of arthritis starts with a knee joint. Now in the knee joint, the major problem is that joint pain. Major problem is that joint pain. Okay, now joint pain, what will happen is that, remember the joint pain, morning pain will be there, but morning tenderness, morning stiffness is less than 45 minutes, less than 45 minutes. And most important factor is that osteoarthritis and rheumatoid arthritis, the interesting thing is that I have a patient who is telling me that she is having a joint pains. Okay, I ask, okay, she's some 60-year-old grandmother. Okay, I asked grandmother, what is the complaint? So once you wake up, how long you have difficulty? She'll tell, I'll have difficulty for about half an hour to walk, later I can walk. Then now you'll ask the next question. As you progress in the day, दिन में आगे बढ़ते बढ़ते, as progress in the day, will your pain reduce or pain increase? Okay, so remember, with the day progression, there is a decrease of the pain. This is an important point. Okay, now joint में pain होगा, joint tenderness, decreased range of motion, and also bony swelling can be seen. Bony swelling, especially if involvement of which joint? Small joints. What is that? Small joints. Okay, so swelling of the distal interphalangeal joints. Look here, distal interphalangeal joint means DIP is involved. Wow, DIP is involved. If DIP is involved, this is the distal interphalangeal joints. If you notice, there is a lots of enlargement of the nodes are there. We call it as a Heberden nodes. This is also a question which was previously asked. Heberden nodes are seen with which disease? Heberden nodes are seen with osteoarthritis. And there is one more interesting one, that is proximal interphalangeal joints. That is PIP. So this is the PIP joints. Here if you find the nodule, we call it as a Bouchard nodule. So how to remember? In the alphabets, B पहले आता है कि H पहले आता है? Which one comes first? B comes first or H comes first? B comes first. तो पहला joint will be what is that? Proximal interphalangeal joint. तो proximal interphalangeal joint में B for Bouchard nodule आएगा. Later on तो H आएगा, like that only distal interphalangeal joint में Heberden nodules दिखेंगे. Okay. So that is the story of your nodules. So again, osteoarthritis patient. Here, look here, the most interesting thing. What is this? My dear students, अगर कोई भी joint ले लो, if you take any joint, the involvement of the joint is one side or both the sides. See, it starts with one side of the joint. Means what I'm trying to tell you is that if one bone is like this, right? If one bone is like this, okay, now the thing what I'm trying to tell you is the involvement will start with one side of the joint. एक तरफ से शुरू होता है, from one side of the joint it will start, then only it will progress. Okay, now सुनो, बात सुनो, बहुत इंटरेस्टिंग चीज है यार, मतलब बता दिए चले गए, ऐसा नहीं होता है. Now क्या, what happens is that two joints were, ये joint was there, joint space is narrowed. पहले क्या होता है, joint space कम होता है. जैसे ही जॉइंट स्पेस कम हो जाएगा, एक दूसरे के साथ ऐसा रब होने लगता है. वन बोन विल रब अगेंस्ट अनदर बोन. So bone rubbing is heart structure. When they rub against each other, bone will be destroyed. दोनों में bone destroyed. As bone will be destroyed, now what will happen? Look here, bone destroyed. If bone is destroyed in one bone, what will happen? In both the bones, destruction is occurred. Now, if destruction has occurred, your body is not going to keep quiet. Pathology में क्या पढ़ाया था? कभी भी destruction होता है तो what will be there? Healing will be there. If there is a healing, what will happen? Small bone fragments will start to come out. Means bone was supposed to be sitting like this. Okay, because of the destruction, small bony fragments will start to pop out, called as osteophyte formation. So I will tell you few points. Remember, in the osteoarthritis, osteophyte formation, osteophytes are nothing but new bone formation. New bone means small bone structures are formed. Okay, that will further damage. Narrowing of the joint space, narrowing of the joint space, narrowing of the joint space. Okay, later on fusion can also occur. Later on क्या हो सकता है, fusion हो सकता है. क्यों? क्योंकि बोन यार एक दूसरे को रब कर रहा था, अब दोनों बोन ग्रो होने लगे. both the bones will grow and they can start to attach each other. So एक बार बोन अटैच होने लगेगा तो ऑटोमेटिकली मूवमेंट विल बी लिमिटेड. तब भी क्या करना पड़ेगा, that is the time we have to do total knee replacement surgery, for example. Okay, so these are the points you must remain regarding the osteoarthritis. So osteophyte, narrowing of the joint space and fusion of the bones can occur, and this is associated with the age. Old age people, knee joints are commonly involved, and if at all your luck is good, this is one of the thing which is less commonly identified clinically but more commonly identified theoretically in textbooks. They will ask you this one called as Baker's cyst. Baker's cyst. Baker's cyst. So there is a cyst called as Baker's cyst. This Baker's cyst can also be associated with what is that, osteoarthritis only. तो आप पूछोगे सर कौन सी पार्ट में आता है? Baker's cyst is in the knee. It can be in the posterior aspect of the knee joint. Posterior aspect of the knee joint. So these are the points to be remembered from the osteoarthritis. Everybody able to understand? Okay. I'm hoping that you're understanding. I'll continue further into the next disease called as systemic lupus erythematosus. Don't rush. Sir, what you would go out? अब तो go out उड़ा दिए. ऐसा कुछ नहीं उड़ाया हूँ. थोड़ा आराम करो. करवाता हूँ. ठीक है. कोई दिक्कत नहीं. Now, SLE, systemic lupus erythematosus. So systemic lupus erythematosus बोलते ही लोगों को ना कंफ्यूज होने लगते हैं, यार कहाँ से क्या शुरू करें, कुछ समझ नहीं आता. We're not understanding what to do. So I will tell you one simple word. Okay, and your complete SLE can be understood. One word is that serositis. Serositis. That's it. What do I mean by serositis? In the body, wherever serosal cavities are there in the body, all of them are affected in SLE. What do I mean by this? So you have pleural cavity. Pleural cavity is a serosal cavity. Pleural space is affected. Okay, for example, you have your joint space. Joints is a plural. Joints is having what is that? Serosal cavity. Joints are affected. Heart pericardium. Pericardium is a serosal cavity. Serosal cavity is affected. So the most of the commonest symptoms are most of the time associated with serositis. Okay. Now this systemic lupus erythematosus कहाँ से शुरू होता है, कब शुरू होता है, मतलब you know what is the underlying cause we don't know. Okay. So same like rheumatoid arthritis. But what we know is that there are some things which can trigger the SLE. Okay. So there are some things which can trigger the SLE such as sunlight. Sunlight की वजह से photosensitive rash बन सकता है. Then drugs. The drugs such as hydralazine, isoniazid, propanamide. Hydralazine, isoniazid, propanamide. They can also trigger the SLE. We call it as a drug-induced SLE. Okay. Very good. Let's go to the next one. Same thing, associated condition. Associate SLE, along with SLE, what can be there? SLE के साथ there can be antiphospholipid syndrome called as Apla syndrome. What is that? Apla syndrome. Apla syndrome usually seen during pregnancy. Apla syndrome can be associated. Very good. Ship drugs, sulfur drugs, isoniazid, propanamide, dapsone. These are the drugs which undergo which reaction? Drugs which undergo acetylation reaction will do what is that? That is your SLE. Okay. इसीलिए बोलते हो ड्रग इंड्यूस्ड SLE है ना. Then lupus nephritis. Lupus nephritis का मतलब होता है, listen to me, there is a inflammation in the kidney. Like glomerulonephritis will occur, but the glomerulonephritis in the in the in the lupus nephritis, we have one very interesting thing. What is that? That is, we find one specific necrosis, wire loop necrosis. Wire loop necrosis. In the pathology, we are going to find a necrosis called as wire loop necrosis in the lupus nephritis. It will lead to nephrotic syndrome. Nephrotic syndrome क्या होता है? Nephrotic syndrome means very good proteinuria. Nephrotic syndrome. So lupus nephritis. So SLE के साथ lupus nephritis हो सकता है. Okay. Good. Then drug induced is like, if there is a drug induced SLE is there, so remember this point: anti-nuclear and anti-histone antibodies, the two antibodies which are typically positive for the SLE, that is drug induced one, anti-nuclear and anti-histone antibodies. It can also be associated with the Liebman-Sack endocarditis, LSC, SLE, LSC. Okay, what is this LSC? Liebman-Sack endocarditis. Liebman-Sack endocarditis means very simple, my dear students. So here what happens that there is an inflammation of endocardium, and also very important thing, this is a type of abacterial. Abacterial means absence of bacteria, or also can be called as a sterile endocarditis. What is that? Sterile endocarditis. Hello. Now, this can also be associated with Raynaud's phenomenon. This can be associated with the Raynaud's phenomenon. And ऐसा नहीं होगा कि SLE people दिन भर रात भर वो SLE करके घूमेंगे. They are not going to have full time complaints. What exactly I'm trying to tell you is that there will be recurrent flares. Means patient will have normal life. Suddenly flare up can occur. Okay. Very good. Good evening. So symptoms, the generalized symptoms, because see, throughout the body connective tissue is involved and inflammation is going on. Because of that, fatigue, fever, weight loss can be there. Okay, along with that, anemia of chronic diseases can be present. Okay, patient will have, I told you people, serositis, that is arthralgia will be there, and also serositis means serosal cavities are inflamed. One of them is pericarditis. Pericarditis means what will happen? So remember, there is one interesting thing. Malar rash पे आते हैं, skin के ऊपर मैं लेके आता हूँ, but उससे पहले देखो, we will understand other things, क्योंकि मुझे बहुत अच्छे से पता है कि आप लोग malar rash बहुत अच्छे जानते हो. ठीक है, pericarditis. Here what can happen is that in the SLE there can be fibrinous pericarditis. So what happens is that as time progress, दोनों pericardial layer, inner pericardium and outer pericardium, दोनों might start to fuse also. Okay, then patient can also have pleural effusion. Myocarditis can also be present. If myocarditis is there, you can find ANA antibody, anti-nuclear antibody, and also you can find double-stranded DNA, dsDNA antibody, anti-Smith antibody, and if the patient is having Sjogren's syndrome, ROLA antibody. Sir, ये क्या पढ़े जा रहे हो? Very simple. There are a list of antibodies which can be found in SLE that includes anti-nuclear antibody. एक हो गया. दूसरा antibody होता है double-stranded DNA, that is anti-dsDNA antibody, then anti-Smith antibody and anti-histone antibody. Okay. For example, if SLE is associated with Sjogren's syndrome, so Sjogren's syndrome will have anti-Rho and anti-La antibodies. वाह, अब तो all of the above हो जाएगा. हाँ, all of them. ठीक है, ऐसा नहीं होता है कि स्पेसिफिकली एक एंटीबॉडी से डायग्नोसिस नहीं बनाते क्लिनिकली. ठीक है, दैट इज एनीथिंग टू बी रिमेंबर्ड. ओके, देन let's continue to the next aspect. What is the next aspect? Also seen in Sjogren's syndrome, and also you can find anti-histone antibody. They're more specific for what is that? Drug-induced SLE. And also patient will have what is that? Malar rash. What is that? Malar rash. Malar rash, if I give you the picture, everyone will be able to answer. Okay, but what I'm thinking, what I want to do is that malar rash, everybody will answer looking at a picture, but let me explain you the most important aspect. So malar rash, why do we call it as malar rash? It is not malar. Okay, it is not some flower here. Okay, I'm talking about malar rash because it is present in the malar eminences. Okay, if you look at this, यहाँ पे देखो, only in the malar eminences it is there. Here is the rash. अरे लड़की के ऊपर फोकस छोड़ो भैया, यहाँ पे रैश के ऊपर फोकस करो, है ना? Look here, malar rash. Okay, so sir, what exactly is left out? ये triangle area, nose and lips, this triangle area, this is only called as nasolabial triangle. Nasolabial triangle or nasolabial fold is spared, matlab it is not having the rash, spared. Okay, पीडीएफ मिल नहीं रहा है क्या तुम्हें? चलो मैं ब्रेक में मैं बात करता हूँ अपना टीम से, ठीक है? वो कैसा क्या हो रहा है मैं पता करता हूँ, ठीक है? कोई दिक्कत नहीं। थैंक यू फॉर ब्रिंगिंग इट टू माय नोटिस। मैं अभी ब्रेक के अंदर, मतलब अभी इमीडिएटली नहीं, जब ब्रेक लेंगे तभी मैं बात करके सॉल्व करता हूँ उस चीज को, ठीक है? चलो, सो व्हाट इज दिस इज स्पेयर, वेरी इंपॉर्टेंट. Okay, so this is a story of your SLE. Then let's go to the next disease called as scleroderma. Scleroderma होता क्या है? Scleroderma is a condition where there is the involvement of very easy to understand, a multi-system involvement. What is that? Multi-system involvement. So in this multi-system involvement, these people with scleroderma, आपको इतना ही याद रखना है, any patient with scleroderma will have crest syndrome. What is this crest syndrome? C for calcinosis cutis. C for calcinosis cutis means a calcium deposition in the skin. Calcium deposition in the skin. In the skin. Calcium deposition in the skin. Okay. Then remember R. R for Raynaud's phenomena. Raynaud's phenomena means what will happen is that distal. What is that? Raynaud's phenomenon and Raynaud's syndrome can progress if these distal areas will have a lack of blood supply. If there is a lack of blood supply to the distal parts of the hand and leg, we call it as a Raynaud's phenomenon. Okay. Then E for esophageal dysmotility. Esophageal dysmotility, especially lower esophagus will have some dysmotility. Then there will be sclerodactyly. So that will sclerodactyly will lead to what? That will lead to limitation of the skin movement, and telangiectasia. Okay, so how many questions can be expected from this, sir? Please, okay, I'll tell you. See, from this video, now the content which I'm going to give you, from that content, yes, you can expect up to 5 to 6 questions. Okay, 5 to 6 क्वेश्चन. बट द थिंग इज दैट देखो, हम ऐसा कर रहे हैं कि और भी ज्यादा है. ओके, मैं ऐसा नहीं बोलूंगा कि मैं पूरा आई गिव यू माउंटेन ऑफ क्वेश्चन, वो झूठ हो जाएगा. I have, like, before 2 3 days before the exam, we are doing a 5 hour session for medicine. उसमें जितना हो पाएगा वो कवर करूंगा. I'm trying to get you up to 10 questions possible. मैं ऐसा जगहों में टारगेट कर रहा हूँ जहाँ पे 100% previously they have involved and asked the questions. Okay, let's continue. Telangiectasia means small thermal flares. Okay, now along with that they will have one interesting thing with their mouth. अगर माउथ के बारे में दिया है तो ऐसा सिम्टम होता है पाउच माउथ. That's fine. See, even if I'm telling something in Hindi, I'm repeating the same thing in English as well. Okay, so do not worry about it. If you have any difficulty, I'll take care of it. Okay, no, yes, thank you for telling that. Now listen to me very carefully. Telangiectasia is there. Along with that, there is one interesting thing about the mouth. Okay, now nobody will take a screenshot and make memes out of this. Okay, patient mouth will be like this. Okay, what happens? Patient mouth will be like this. Okay, so patient will have folds on the mouth, and the patient will not be able to do the proper motility of the mouth and lips. Okay, so that is pouch like mouth. If you get a picture with patient having difficulty in swallowing and mouth shown to be like this, or skin shown to skin is like this, okay, the skin is like this, then you need to understand they're talking about scleroderma. Okay, if they are talking about lower esophageal dysmotility, along with that, like, if you can't understand what systems are coming, esophagus came suddenly, skin came suddenly, blood vessels came, then you need to think of scleroderma, my dear. Then you need to think of scleroderma, pouch like mouth. Okay, very, very important. Now here you can find centromere antibody. Now here you need to remember. Okay, what is that? You need to remember centromere antibody. Okay, then you can also find that is SCL70 are also called as anti-DNA topoisomerase antibody. So what you are trying to tell? So I'm trying to tell you people is that, see, anti-nuclear antibodies are found in both SLA and scleroderma. So this one will become a useless, right? So, but these one, centromere and SCL70 antibodies are specific to scleroderma rather than your SLE. That's what I'm trying to tell you. Okay. Now, all the above mentioned diseases, SLE, scleroderma, all the osteoarthritis more common in female. Okay. Let's go to the next and last disease, which is very important one. That is your ankylosing spondylitis. Ankylosing spondylitis is a condition in which most commonly affected is male, in which most commonly affected one is male. Most commonly affected person is what? Male. Most commonly affected person is what? Male. Okay, so remember, male and also young. Okay, so what happens is that this is a disease which will affect two places. Okay, one is sacroiliac joint, sacroiliac joint, where sacrum and iliac bone are fusing, that joint is affected. And one more is spine is affected. In the spine, what happens, what happens, exactly, one vertebra is there, another vertebra is there. From one vertebra to another vertebra, space will be there, right? Space will be there. Now यहाँ पे the space will disappear, narrowing of the space of, what is that? Very good, joint space of the vertebra. So if joint space of the vertebra is narrowed, what will happen to the person? Joints will start to fuse. If joints will start to fuse, spine is open. So what will happen? At one point, this fusion will lead to limitation of the movement. ऐसा ऐसा bend नहीं कर पाएंगे, they can't be able to do all this. So now what will happen is that patient will come into this position, okay, lean forward position, like a beggar position. Okay, so because of the fusion of the joint, patient will get into beggar position. That is only. Now it is associated with very ankylosing. Ankylosing means, what is that? Ankylosing means fusion of joints. Okay, now what happens here is that HLA-B27 is the gene. BR4 is with rheumatoid arthritis, B27 is with ankylosing spondylitis. It is the HLA-B27. HLA-B27 can be positive. Okay, now ankylosing spondylitis is not a single disorder, my dear. It is not a single disorder. So what is this, sir? This is a disorder which can be associated with other, means ankylosing spondylitis. Ankylosing spondylitis can be associated with PAIR, pair. That is psoriasis. Ankylosing spondylitis can be associated with psoriasis. Means psoriasis can have two types of arthritis. One is psoriatic arthritis, one is ankylosing spondylitis. Then one more thing, HLA-B27 can also be associated with ankylosing spondylitis itself. It is also associated with IBD, inflammatory bowel diseases, and also HLA-B27 can be associated with the reactive arthritis. So this gene can be associated with 4 of them pair, and all this pair is one interesting thing, they are seronegative. So only one seropositive arthritis is rheumatoid, rest everything is a seronegative arthritis. All right. So now if fusion of the spine is occurring, what is the clinical feature? Remember, the clinical feature of this patient will be lower back pain. Lower back pain. Lower back pain. Okay. Juvenile rheumatoid arthritis. Okay, you got that. So lower back pain will be the most common complaint. Then later, limitation of the movements will be there. Now the examiner is not interested in giving you all this. Okay, he will put one picture, tape deta wo ek picture tape deta. So he'll put that picture and he'll ask you what is the diagnosis for this patient. Okay, it is very easy. This is a picture. This is a picture of what is that? That is your ankylosing spondylitis. Everybody tell me the diagnosis in this. All of you फटाफट डाल दोगे. ऑलरेडी आ भी गए, एक तो आ भी गया कि बैम्बू स्पाइन. ठीक है, अरे यार हमेशा यहाँ पे ही क्यों देखते हो? When I say the spine, why you are noticing only in this area? But when I have given you an X-ray, why we should not do this also? We should do this also, right? Look here, here is your sacral bone, here is your iliac bone. Can you notice sacroiliac joint at all? Can you notice sacroiliac joint at all? No, you cannot notice sacroiliac joint because there is a fusion of the joint. Notice here. Fusion of the joint. Along with that, all the vertebrae are fused. This vertebra which is fused, it looks like a bamboo, called as bamboo spine. Bamboo spine. Okay. Now, if you look at the central part, the spinal processes of the vertebra has what is that? Has giving you a look like a dagger. Okay, what is that? Dagger spine. Okay, dagger spine. Okay, So that is the story of your dagger spine and also bamboo spine and fusion of the sacroiliac joint. So ankylosing spondylitis, miracle, very simple. HLA B27 seen with the very good males only, and bamboo spine, dagger spine. It can be HLA B27 can be associated with pain. Everything is finished except for one thing. What exactly is that? Investigation. Investigation is a very interesting question which can be asked from this question topic. Listen to me. The investigation, what we are going to do for ankylosing spondylitis, I'll tell you. Initially, we can do X-ray. Initially, we can do X-ray. Okay. Best one is for HLA B27. Find the HLA B27 itself, genetic investigation. And also you can go for MRI because for the sacroiliac joint, MRI for the sacroiliac joint, sacroiliac joint, okay, sacroiliac joint. So अभी आप लोगों को now you people must be should be thinking what is that? Ankylosing spondylitis have association with the psoriasis, inflammatory bowel disease and reactive arthritis. So this is the story of your rheumatology important points. Understood everybody? Chalo, let's go to the questions. Let's look at this question and let's try to answer. IOC, if they ask you IOC is HLA B27. IOC. Radiological IOC is MRI. Radiological IOC is MRI. First investigation is X-ray. Let's go to this one. A 67-year-old male with no significant medical history comes to your office complaining of pain and stiffness in the hand. Upon waking in the morning, you perform an X-ray, shows the picture. Following is the likely diagnosis. Batao. Tell me, let's see. So first and most important, Q by stiffness is there, but they haven't mentioned the duration of stiffness. If you are diagnosing rheumatoid arthritis, the most important thing you must be telling is more than 45 minutes. Here time is not specified, so you can't really tell it as rheumatoid arthritis. And look here, wow, distal interphalangeal joints in the hand X-ray, you can see distal interphalangeal joints, the solid node-like formation. So there is a solid nodes on which joint? In the distal interphalangeal joint. Where did I tell you? Nodes in the distal interphalangeal joint. In which disease? Heberden nodule and Bouchard nodule. So Heberden nodules are seen with osteoarthritis. So examiner also knows that osteoarthritis, as soon as you tell, you might go to what? You might go to knee. So that is why he will give you this type of question. Okay, remember Heberden nodule and Bouchard nodules are seen with that is your osteoarthritis. Okay, now rheumatoid arthritis means there should be distal. DIPs are spared here, my dear sir. DIP is spared. Okay, very important. Okay, happens. अभी एग्जाम के अंदर नहीं हो, अभी एग्जाम से बाहर ही हो, सो कितने भी गलत तो कर सकते हो यहाँ पे, ठीक है. लेट्स गो टू द सेकंड क्वेश्चन. A 45-year-old male with no significant medical history comes to your office complaining of pain and stiffness upon waking up in the morning for past several months. The stiffness generally lasts 1 to 2 hours for your patient. You perform an X-ray. If the X-ray reveals this one, what is the diagnosis? देखो मैं क्या पढ़ाया था आप लोगों को. What did I tell you people? If there is more than 45 minutes, if that is there, rheumatoid arthritis, to confirm your suspicion, here I have clearly told you people what is there. Look at this, there is a deviation which is occurring. Notice here very carefully, right? Very good. So no deviation is occurring towards what? Look here, deviation is going towards the ulna. You have a ulnar deviation. Ulnar deviation is seen with rheumatoid arthritis. Seen with what? Rheumatoid arthritis. Clear? Very good. Let's go to the next question. A 20-year-old woman present to her primary care provider complaining of a facial rash, says about the rash, okay, and experienced a pain in the hands and wrist that worsened in the morning accompanied by a subjective fevers. Examination demonstrates a rash on the patient's face, spares the nasolabial folds along with orals. What is the next best step? What is the next best step? So first, she's having a rash in the face, but these folds are spared. If forced, if they are spared, you are suspected of SLE, malar rash. Okay. If malar rash is there, now what is the next best step in diagnosis? Okay. Now let's understand one by one. Okay. So cardiolipin antibodies are not useful. They are associated with Apla syndrome. Now you are left with three other antibodies. ANA antibodies are found with two places. ANA कहाँ कहाँ मिलता है? Scleroderma, and also ANA antibodies can be found in where? In the SLE. Now again, it is not a very specific, not of use. Antihistone antibodies are specific to what? Drug induced SLE. But anti-dsDNA, double stranded DNA antibodies, anti-dsDNA antibodies are specific for systemic lupus erythematosus. The best answer would be B. Okay. Other anti-DS antibodies are not there in the option, then second best option is D. Second best option is D. Now, these are previous year questions are इतना difficult आते हैं कि नहीं. So the questions which were simple to explain you the whole disease in one question, I have improvised that question to be more difficult so that even in the worst case scenario, you people will not be scared. Okay. So remember, anti-DS DNA or Smith antibodies would be better for you. Okay. Let's go to the next question. चलिए आगे बढ़ते हैं. A 38-year-old woman comes to the clinic complaining of general malaise and facial rash. She reports that the rash began 1 week ago after she had been playing outside with her dog. So she was exposed to the sunlight. After the sunlight, she had a rash. Wow, does sound similar. SLE, photosensitivity rash. Right? On physical examination, you appreciate a oral ulcer, mild joint stiffness, swelling of the patient hands and knees. A photograph of the patient facial rash is given below. यहाँ पे दिया हुआ. You feel her current presentation is drug related. Which of the following medication could be causing her symptoms? So what you're trying to tell you, she's having a complaints of SLE. Okay, and doctor thinking that it could be caused by drugs. So which of the drugs causes SLE? Tell me. This one I'm not going to give you answer. First tell me, you people should tell me, then I'll explain. See, symptoms of SLE are there. Doctor is the examiner are asking you which drug can cause SLE. Very good. One answer came. Any other answers? हाँ, वहां पे ऑप्शन में देखो, एबीसीडी देखो, एबीसीडी में बदले का बताओ आंसर. Very good, very good. You people are absolutely right. The answer is hydralazine. The answer is hydralazine. Okay. So remember the drugs which causes SLE. Drugs causing SLE are your ship drugs. Sulfur drugs, hydralazine, hydralazine. Hydralazine is safe to use in pregnancy. Okay. Hydralazine, isoniazid, okay, and procainamide, and as well as your dapsone. Okay, so all these drugs, what is the common point of them? They cause SLE, and also, my dear students, these drugs undergo a reaction called as acetylation from pharmacology. So during their metabolism, they undergo acetylation reaction. Okay, let's go to the next one. Next question. A 47-year-old woman presents with the complaints of her hands are often cold and painful. Hands are being cold and painful. Examination of her hands without gloves shows her fingers are held in a flexion bilaterally along with the finding in the picture. So here we can find these findings. Okay. Here you can find these findings. Okay. Okay. The pulmonary examination is significant for bilateral inspiratory crackles. Which of the following additionally found in this patient? Okay. Let's see. She is having Raynaud's phenomenon and calcinosis cutis. You can notice this is a calcinosis cutis. This is also a calcinosis cutis. So she is having Raynaud's phenomenon and calcinosis cutis. So what can be one more thing which can be present to this person? What can be present to this person? So I told you people. So calcinosis cutis and your what is that? and your Raynaud's are your, what is the part of your crust syndrome, right? So what else can be there? So T for telangiectasia. Look here, is there any telangiectasia? No. All right. Yes, for sclerodactyly, is there anything related to sclerodactyly? No. So among these three, one, two are given. Okay. So what we are left out with? So we are left out with increased lower esophageal sphincter tone, lower esophageal and sphincter atrophy and fibrosis. Remember, it is not about the tone. Dysmotility occurs as a result of fibrosis, as a result of atrophy and fibrosis. The answer is D. Okay, lower esophageal sphincter tone is increased in achalasia cardia. Here what will happen, it is a connective tissue disease, my dear. What will happen is that esophagus will undergo fibrosis. Got the point? Got it? Okay, let's go to the next question. I know that these are exceptionally high level questions, but the purpose here is to make you people make sure that you understood. Okay, a 21-year-old man presents with the itna difficult question nahi aaye hai. We have improvised the question for your betterment. A 21-year-old man presents with the severe morning back pain over the past 3 months. His pain improves as day progresses with exercise. Physical examination shows diminished anterior flexion of the lumbar spine. Remember, he is not able to bend forward. Anterior flexion is damaged. Okay. Radiography of the lumbar spine shows bilateral sclerotic changes. Okay, in the sacroiliac region, means in both the sacroiliac joints, sclerosis means connective tissue fibrosis can be there. All of the following about this patient can be true except. So look here, 21-year young man complains with a lower back pain and is having failure of flexion. It is suspected of ankylosing spondylitis. So what and all can be seen in ankylosing spondylitis except? Okay, that's very nice. Okay, so what is the thing which cannot be found? Very good. We cannot find rheumatoid factor positive because it is a rheumatoid factor negative except pucha gaya. Except. Very good, very good everyone. Okay, let's go to the next one. Now what is this one? A 32-year-old woman presents to with redness of the eyes as well as a discharge. Reports that he experiences pain with urination and stiffness of pain in the knee, and a complete blood count reveals erythrocyte sedimentation rate is 40. Toe radiograph demonstrates soft tissue swelling but no fractures. Which diagnostic test should be performed? अब बताओ इसका diagnosis. So I'll teach you people. He's having an arthritis. And discharge from the eye, redness and discharge from the eye, suggestive of conjunctivitis. Okay, and also he is having, what is that? He is having, my dear students, reports pain with the urination, suggestive of urethritis, arthritis, conjunctivitis, urethritis. All these three are a symptom of all these three. अच्छा, ओके, अगर आप ट्रिपल ए का स्टूडेंट हो तो फिर तो you know this very well. मैं क्या बोलने वाला हूँ इस डिसीज को लेके, right? So the answer will be, what is that? Reiter's syndrome. Answer of the triad is Reiter's syndrome. What is that? Reiter's syndrome. ठीक है? So what do I mean by Reiter's syndrome? Reiter's syndrome means it is a disease. तुम्हारा कर्मों के वजह से होता है. Because of the actions you do, you will end up having this Reiter's syndrome. What do I mean by this? Reiter's syndrome will come after urethritis. Urethritis क्यों होता है पता है? You know why? Because if the female has for example, female has chlamydia. Now male did not. They had an intercourse, unprotected sex, followed by the unprotected sex, right? So he will have, what is that? Urethritis. Okay. Then they had an intercourse followed by the urethritis. The joints will get affected. Arthritis. Action ज़्यादा नहीं करना चाहिए. You shouldn't have done much action, so now joints are suffering. Okay, now you shouldn't have seen much. So what happens? What is that? That is your conjunctivitis. So this is a way to remember arthritis, conjunctivitis, and urethritis. First, everything starts with urethritis followed by arthritis and conjunctivitis. This is a triad called as Reiter's syndrome. Reiter's syndrome is a type of which disease? It is a type of reactive arthritis. reactive arthritis. Okay, so reactive arthritis is there. So for that only we do nucleic acid amplification testing for chlamydia trachomatis. तो इसके लिए kit 1 use कर सकते हो from PSF. But remember this part, DNA is what is that? Option D is the correct answer. You are going to check for amplification techniques for what is that? Chlamydia trachomatis. Okay, chlamydia trachomatis is a sexually transmitting disease. Let's go to the next point. A 4-year-old boy presents to the emergency room with abdominal pain. Mother reports that he had a rash for about a week on his lower extremities as well as joint pain and blood in his urine. Yesterday I told you people vasculitis के बारे में मैं आगे पढ़ाऊंगा करके ये रहा. Okay. Now listen to me. See, that doesn't matter. We are Indian. We can use both. Okay. A 4-year-old boy presents to the emergency room with abdominal pain. His mother reports that he had a rash for about a week on his lower extremities as well as joint pain and blood in his urine. Okay. Physical examination reveals palpable purpura on his buttocks and also lower legs and abdominal tenderness is there. What is the diagnosis? So remember, what are the clinical feature? Purpura. Okay. Joint pain, abdominal pain, and also that is blood in his urine. Blood is in urine is nothing but glomerulonephritis. All of these four of them together, is seen with a disease called as Henoch-Schönlein purpura. What is that? Henoch-Schönlein purpura. It is a type of immune complex small vessel vasculitis. It is a type of immune complex small vessel vasculitis seen in children. Okay, this is the points to be remembered. Okay, now if you go and check for example, glomerulonephritis is there. If there is a glomerulonephritis, what you can go for what is that? You can go for the biopsy and you can look it under a microscope. There in the fluorescent microscope you can find IgA deposits. Okay, so these are the story of your what is that? Henoch-Schönlein purpura. Very good, Kumar Amit. The answer is correct. So here we have the best answer is Henoch-Schönlein purpura. Okay, ITP immune thrombocytopenic purpura is seen with adults, not with children. Usually it is seen with adults. Let's go to the next question. A 57-year-old man presents to the emergency department with a sudden severe pain in his ankle. He has experienced this pain before but states that this time pain did not respond to high doses of ibuprofen and naproxen. He used NSAID, he did not respond. The patient has a past medical history of hypertension. पकड़ो यहाँ पे इसको पकड़ो, hypertension. भाई मैं पहचान नहीं पा रहा हूँ यार. That is the problem. I'm not able to guess. About intussusception. लास्ट में याद दिला दे, समझा देंगे उसमें क्या दिक्कत है. ठीक है. अब मैं तुम नाम जो रखे उसको तो मैं लेके नहीं आ सकता. ठीक है. Hypertension was treated with hydrochlorothiazide. Physical examination revealed tender inflamed ankle that cannot be manipulated due to severe pain. Which of the following would be most likely found in this patient? Okay. So narrowing of the joint space in weight bearing joints. Any other answers? अरे हम पे तो इतना मस्त हिंट दिया, हाइड्रोक्लोरोथायजाइड. Okay, now I will teach you one complete disorder. Listen to me, then we will come back to this one. Okay, I will teach you one complete disease, then we will come back to this. Okay, so what is the name of the disease? Let's study with the gout. Okay, gout is a type of, my dear students, it is a type of crystal arthritis. What is that? Crystal arthritis. Gout is a type of crystal arthritis. Here what happens is that in the joints, what is there? There is something called as MSU crystals. What is that called as? MSU crystals. What is MSU crystals? They are nothing but monosodium urate crystal. Monosodium urate crystal. Now monosodium urate crystals, what will happen? Any condition, if there is an increase of urea, now this urea will lead to forms What is that? Monosodium urate crystal. ये monosodium urate crystal जाके कहाँ पे बैठता है? Sit in the joints. They will go and sit where? Sit in the joints. Sit in where? In the joints. If they sit in the joints, the problem is what? If they sit in the joint and they will cause problems such as damage the joint. Okay, they also trigger inflammation in the joint, and also they get deposited in the joint. Okay, now the problem here is very easy to understand. They sit in the joints, and there is a inflammation, and also they're causing what? Damage of the joint space, and also deposited. Now these monosodium urate crystals, whenever they are deposited, we are going to have some problems. Now we are going to have some problems. I will let you answer, do not worry, but सुन लो अभी 1 मिनट के लिए. Okay, now these monosodium urate crystals are sat there. Okay, now they will sit there, and what exactly is this disease? This is only your gout, right? Now in the gout, remember the risk factors for the gout. The risk factors for the gout are some drugs, especially and most importantly, your thiazide diuretics. Especially and most importantly, thiazide diuretics. Okay, definitely. Now that's the first point. Second point, what is that? That is the most important risk factor is alcohol. That is your alcohol, and also excessive amount of meat. Okay, excessive amount of meat. Now all of these things increase the risk of gout. Okay, thiazides, why will they cause gout? They increase the urea reabsorption. Normally urea should going in the urine. Instead of urea going in the urine, urea will be taken back when you take a thiazide drugs. Okay, so what exactly you are going to do? So the clinical manifestation of the gout can be classified into two types: acute gout, and also you'll have a chronic gout. In chronic gout, pain is not there, pain absent. Okay, here in acute gout, sudden onset. Okay, and patient will also have history of gout. Means the patient had gout, usko gout to tha hi, he had gout, but he was not having any problem. He thought, oh my god, I don't have any problems now I will have 2 pegs. Night he will have 2 pegs. After that he don't know how many pegs he had, but morning he'll come, sir, I'm having severe pain, I'm not able to move. He won't even let, okay, I will look, just let me look at the joint. You try to move the joint, he'll react with that much pain. Yes, this has been brought to my notice. I will solve this in the break, I have told. Okay. Now the problem here is that he will have a sudden history of gout. Now the thing is that, my dear students, what exactly is that treatment? The treatment for both of them is different. What is the treatment for acute gout? NSAIDs. If NSAIDs is not responding, it's all the other name is called Podobra. We don't use it anymore. Okay. Now NSAIDs. This is a standard Ukraine name. Okay, NSAIDs. Now, along with NSAIDs, we also use what is it? Colchicine. Colchicine. Any hyperuricemic condition, we can consider colchicine, even for the uremic pericarditis. For the uremic pericarditis, also drug of choice is colchicine only. For the chronic, we use drugs such as a xanthine oxidase inhibitor, that is allopurinol. And also we have other drugs such as febuxostat. What is that? Febuxostat. Okay. So remember, in the acute gout, again important point. They in the acute gout is a contraindication for allopurinol. Okay. Clear? Okay, yeah, that is a good mnemonic to remember. Acute colchicine, chronic allopurinol. Okay, now as I found the answers. So what is the answer? Let's see now. Very good. The answer is what you're going to find. Severe pain is there. So now what you are going to do is that you did a arthrosynthesis. That is the point which I wanted to teach you people with the question. So you did a arthrosynthesis. Arthrosynthesis means the patient is having the joint pain. You put one needle. You take the synovial fluid. Look it under. Remember, synovial fluid under a polarized microscope. Polarized microscope. Under a polarized microscope, the monosodium urate crystals are there. Na? You will find birefringent. Just remember, these polarized microscopes will have birefringent, non-refringent crystals. Okay, just remember birefringent, needle-like crystals. Birefringent needle-like crystals. If you find birefringent nodal-like crystal, that is telling you a gout. So these are suggesting of gout. The answer is absolutely correct. That is C, C, C. Okay. So birefringent crystals and the arthrosynthesis. Look here, polarized microscope. Okay. Birefringent needle-like, needle-like crystals can be found. Okay. ऐसा दिखेंगे वो. Okay, so this type of crystals can be found. Agar in the polarized microscope, if you find a rhomboid crystal, rhomboid crystal के लिए classic rhomboid shape में कौन रहता है? The classic one is Kaju Katli. Okay, you'll have Kaju Katli approximately in this shape, rhomboid shape. So rhomboid shape. In the rhomboid crystal, if they are there, we call the name of this crystal is what do we call this? Calcium pyrophosphate crystal. Calcium pyrophosphate crystals. Okay. So these are questions which are collected from many years, not just one particular year. Okay. These are just questions collected and improvised from multiple years. Okay. Calcium pyrophosphate crystal. These are your arthro. These are your pseudo gout. So if you find this type of crystal, we call them as a pseudo gout. We call them as a pseudo gout. Okay, let's go to the next one. A 45-year-old man present to the emergency department for sudden pain in his foot. The patient states that he woke up experiencing severe pain in his right great toe. Which one of the following is indicated in? Which one of the following is indicated in the initial management of this patient? Tell me now. Come on, tell me. What will you give this patient? Initial management. ध्यान रखो यहाँ पे क्या पूछा गया? Initial management. Now, at this point of time, when he is having a symptom, severe gout का symptoms are there. That time, what will you do? Come on, tell me the answer. I'm looking at the phone only for your comments. See, it is a. I told you people. What did I tell you? In acute gout, do you give, my dear? It's acute gout. He woke up suddenly, is experiencing pain. In acute gout, do you give allopurinol for initial management? I didn't ask what is not given. I asked what is given. Allopurinol is not given in acute gout. हाँ, allopurinol is not given in acute gout. यही तो trap है. तुम लोग वहां पे नॉट ऑप्शन मतलब क्वेश्चन में विच ऑफ द फॉलोइंग इज नॉट गिवन ऐसा है ही नहीं. दैट इज नॉट देयर ओनली. सो द आंसर इज योर कोलचिसिन. द आंसर इज योर कोलचिसिन. इसी को बोलते हो जब जब एक ही चीज को हम लोग व्हेन वी स्टडीड राइट allopurinol contraindicated in acute gout, contraindicated in acute gout. So when I give a initial management करके पूछूंगा तो तुम्हें बाइंड ऑटोमेटिकली बोलेगा contraindication. No, it's not contraindication. I ask which is the first initial investigation. The answer is your colchicine. What is that? Colchicine. Allopurinol and probenecid. Remember allopurinol and probenecid. These both drugs are used only in chronic gout. Okay, and if any gout, be it acute gout, be it chronic gout, hydrochlorothiazide is contraindicated in gout. In the above question only, I taught you people, he was taking hydrochlorothiazide for hypertension. Okay, chalo, let's go to the next question. So what is this? Let's look at a 72-year-old woman with a past medical history of diabetes and obesity. Arey, diabetes, obesity with a joint pain. Wow, kya majedar. She has severe pain in both of her knees, which she has been taking ibuprofen daily. Physical examination is notable for findings in the image. Radiograph of the knee is shown below in the figure B. Which of the following is most likely diagnosis? So, wow, this is the picture of the patient. Look at this. Now you should tell me what is the diagnosis. She's having diabetes. She's having obesity. She's having knee joint pain. And also she's having these findings. Tell the answer. Let's see. Come on, guys. So what you're finding, see, look here, distal interphalangeal joint is involved. Yes, DIP is involved. If DIP is involved, it is not rheumatoid arthritis. So what exactly is this? This is a condition of यार 60 साल की बुड्ढी को 72-year-old वुमेन को क्यों यार रिएक्टिव आर्थराइटिस लाते हो? रिएक्टिव आर्थराइटिस आता है किसको? हाँ, in young people who has a unprotected sexual intercourse if the person is having chlamydia urethritis, है ना? ठीक है, चलो, by mistake you might have sent it, I agree. The answer is not rheumatoid arthritis, the answer is osteoarthritis. भाई, osteoarthritis क्यों? देखो, look here, distal interphalangeal joints involve हो चुके. If they're involved, they're not involved in rheumatoid arthritis. Why are you rushing? They're not involved in rheumatoid arthritis. In osteoarthritis, DAP is involved. Which nodules here? Heberden nodules are there. And if you notice here, Bouchard's nodules are there, Bouchard's nodules, okay. And in the knee joint, मैं क्या बोला था, joint का एक तरफ involve होता है. Most of the time it starts with one side of the joint. देखो यहाँ पे एक तरफ joint fusion होने लगा है and narrowing of the joint space. What is the answer? Osteoarthritis. इतना सब देखने का जरूरत है क्या? नहीं था sir. How could have answered? ओल्ड एज, ओबेसिटी, डायबिटीज, जॉइंट पेन, ये भी तो बोल सकता था ना ऑस्टियोआर्थराइटिस. यू अंडरस्टूड व्हाई आई पुट दिस मच लेंथी क्वेश्चन to make you understand everything. So this is the type of outline of picture you are going to get for a osteoarthritis. Okay. So here anyways I had one picture तो ऐसे डाल दिया. Osteoporosis and healthy bone का difference देख लो कैसा रहता है. Osteoporosis में bone is being destroyed, here bone is very strong. Okay, मतलब this is for just understanding, because in the old age she can also have osteoporosis of the bones. Okay, so this is a story of your what is that, rheumatology. And we have here is about the gout. Gout के अंदर most important points are monosodium urate crystal, birefringence, and allopurinol is contraindicated in acute gout. Acute gout का drug of choice NSAID है. ठीक है. So what is the treatment for osteoarthritis? यार old age है, joint fuse होने लगा है, once inflammation has started, what can we do? Nothing. Support करो उनको. So what is the treatment? First is initially drugs such as NSAIDs, and also you can give steroids, okay, so you can give NSAIDs and steroids, both of them. Okay, estrogen is not of use anyways, so bone density बढ़ा सकते हो, such as SERMs can be considered. Okay, but the last step when there is no mobility of the joint, when joint is not moving, only at that time you can go for TKR, total knee replacement surgery. TKR, okay, total knee replacement surgery. Okay, so the answer is total knee replacement surgery. Okay, so this is the story of your what is that, story of your rheumatology, with this much being said, we will have a small break of 10 minutes. Okay, we'll have a small break of 10, let's keep it as a 15 minutes. We will come back and start at 6:30. Okay, from 6:30 we will start and we will go till 8:30, 9 o'clock. Okay, there I will teach you people endocrine and cardiovascular. And if you want any of your friends, invite all of them. You are getting one big advantage. Within the next few hours I will teach you about ECG. It is not going to be like, from very small things. I'll teach you what ECGs you must learn for the exam and how to tackle any ECG thrown at you. And I'm going to teach you with the murmurs as well. So these are going to be very interesting and useful concepts for you people, and I'm going to do them quickly, and I will make you practice them with the images what we have also. Okay, all right, with this much being said, come back at 6:30, we'll start then. Okay. Hello students, welcome back. Can you hear me? Okay, perfect. So all of you are asking about the notes. The notes issue has been solved. Okay. So in the video description, in this video description, so where you have live chat, now if you close the live chat, if you just press on the cross in the live chat, and in the below the name there is a video description. In the video description, Dr. Maruti PDF folder link will be there. You can access from there. Okay. So that is your, what is that? That is your notes related issue that is sorted. Okay. Can we proceed further? So as I have told you people, once we are done with this particular concept of your rheumatology, let's go to the next discussion. That is your endocrine with the clinical case scenarios. Okay. So with the clinical case scenarios, let's discuss about the endocrine. But in this endocrine discussion, listen to me very carefully. I have mixed a lot of different subjects also. Okay, so some little bit of neurology has been added. Okay, so let's discuss all of them. Okay, so the next question is, a 7-year-old boy is brought to the clinic and the father reports that the patient is more energetic, but his teacher is still complaining him of spacing out. The word clearly, it is mentioning that spacing out is there. Okay, during the class, the parents reports that it is difficult to follow in class sometimes because teacher would just skip ahead suddenly. Okay, so skip ahead suddenly. What is the mechanism of the drug given to this patient? First and most important thing what we need to understand, if a child is spacing out means वो क्या होता है पता है? वो मतलब डे ड्रीमिंग बोल सकते हो उसको, क्या बोल सकते हो? डे ड्रीमिंग क्या होता है पता है? बच्चा क्लास में बैठा होगा. So again, I'm telling you people, the notes is present in the video description. There is a link. Dr. Maruti's PDF folder link is there. In that, if you open, all the notes for my classes will be there. Already it has been uploaded till the last class of pathology. Only thing which is pending is after today's session is done, I will give the notes of medicine also. That will also be updated. Okay. चलो. Now what I'm trying to tell you, spacing out suddenly मतलब अचानक से क्या होता है पता है? The child will be sitting in the class, suddenly he'll be like this. Teacher is talking to him, telling something, कुछ नहीं, वो पूरा few seconds he's lost. After few seconds he's back. What happened? Okay. So this type of spacing out, this is a classic indicator of, that is a classic indicator of, what is that? The classic indicator of absent seizures. Absent seizures. Okay, so what exactly is the treatment for this child? Okay, so usually we tell valproate is given. Now along with the valproate, please listen to me. So if the child age is less than 2 years, the drug is ethosuxamide. Okay, from the chapter of seizures. If the child age is less than 2 years, for an absent seizure, drug is ethosuxamide, which blocks the calcium channels. Okay, so what is the treatment? That best answer would be B. Best answer would be B, because more than 2 years we give valproate. But valproate has a multiple mechanism. He is asking you to point out one drug, one mechanism. So we are trying to point out the one drug, one mechanism, that is your T-type calcium channel blocker, T-type calcium channel blocker, that is your ethosuxamide. Okay, let's go to the next one. A 16-year-old boy with a history of seizure disorder is rushed to the emergency department with multiple generalized tonic-clonic seizures that have spanned more than 30 minutes in duration. He has not regained the consciousness in these episodes. Which of the following is the appropriate initial treatment for this patient? Okay. Yeah, I already announced the issue about the PDF is solved. All the video links, all the PDFs has been uploaded on a folder, and that folder link is given in the description of the video. There is a Dr. Maruti's PDF folder link will be there. If you click on that, all the notes are available there. Point number one. Point number two, till the last class of pathology, they are updated, and after the class is done, I will give this notes also. They will upload it. Okay, that is put in the comments also. Okay, now look here. What I'm trying to tell you, the child is having a GTCS, generalized tonic-clonic seizures. Now in this generalized tonic-clonic seizures, my dear students, what is happening? One episode of the seizure is there. Okay, seizure. Now next episode of the seizure, between two episodes, the child is not having a consciousness. He is still under a loss of consciousness. If there is a loss of consciousness between two episodes of the seizure, we call it as, my dear students, that is only called as status epilepticus. What is that? Status epilepticus. Status epilepticus. What is status epilepticus? Loss of consciousness between two consecutive seizures. Okay. Now, if there is a loss of consciousness between two consecutive seizures, what is the initial treatment? Remember, so status epilepticus, the first line management is always IV benzodiazepines. IV benzodiazepine, lorazepam. The first line management is IV lorazepam. Lorazepam is a benzodiazepine. If lorazepam is not there in the option, find for what is that? Very good. The next option you are going to find is that is your midazolam. Okay, midazolam and lorazepam. You can try both of them. If they don't respond, then you go for the second drug such as the phenytoin or phosphenytoin. But the first drug is always your what is it? Lorazepam. Okay. Let's go to the next question. So, an 18-year-old Hispanic female presents to the neurologist for the follow-up regarding her treatment for generalized tonic-clonic seizures. She happily reports that seizure has been gone for past 5 months. Means she is not getting any seizure for past 5 months. Her current pharmacological treatment began. However, she states that she is concerned because she noticed recent cosmetically unpleasanting appearance like this. So what is this? This is a classic gum hyperplasia. Gum hyperplasia is there. So what I'm trying to tell you, doctor gave her some drug. So she's telling that for past 5 months she is not having any symptoms of seizure, no problem, but she is getting only this problem, that is gum hyperplasia. What is a drug? She was being treated with the side effect. Gum hyperplasia is a side effect of one drug. The side effect of a drug called as phenytoin. So the side effect of phenytoin is gum hyperplasia. The answer is D, gum hyperplasia. Phenytoin is causing gum hyperplasia. So why does phenytoin causes gum hyperplasia? Because it inhibits one enzyme. It inhibits an enzyme called as collagenase. It will inhibit an enzyme called as collagenase. Because of inhibition of collagenase, it will cause gum hypertrophy. This is a very, very important point to be remembered. There are other drugs also which cause gum hyperplasia, such as calcium channel blockers. The two amlodipine and nifedipine, specifically amlodipine also causes gum hyperplasia. So these are the drugs which cause gum hyperplasia. And remember, gum hyperplasia of the phenytoin is due to the effect called as inhibition of an enzyme called as collagenase. Okay. Let's go to the next question. A 27-year-old unconscious man is brought to the emergency department. A patient smells of alcohol. Physical examination revealed bruising and ecchymosis in the right temple. Okay, 1 mm pupil dilated, 1 mm pupil bilaterally. His temperature is 97.1. Okay, the blood pressure is 84/58. Pulse is 71. Okay, respiration is 8 mm. Followed by the stabilization and respiratory support. What should be the next step for this patient? Now look here, the patient is brought to the hospital. Okay, now what happened? He is having physical examination. Ecchymosis means some bleeding under the right temporal bone. Agreed. But the problem here is that 1 mm pupil is a very narrowed, and the blood pressure is also less. Respiratory rate is also less, and he is having a breath of what is that? Smells of alcohol. Alcohol overdose will lead to what? I'll tell you. Alcohol overdose will lead to decrease of respiratory rate, decrease of BP, and also it can cause pinpoint pupil at a last stage. Pinpoint pupil. Okay, now the most important problem is that is not the end of the story. What exactly is the next step for this patient? Okay, now listen to me. So now the answer will be your ethyl alcohol. If it is not there in the option, antidote for alcohol overdose is what? Flumazenil. Can you give flumazenil to this patient? No, you cannot give flumazenil. So what will be the treatment? So now the treatment is, you need to think is that here respiratory rate and BP is decreased with alcohol, but pinpoint pupil is very specific to one disease. What is the specific to disease? It is specific to one of the diseases. Decreased BP, decreased respiratory rate, and pinpoint pupil. If pinpoint pupil is added with these two things, the most important characteristic is opioid overdose. opioid overdose. ओके हाँ गूगली क्वेश्चन बहुत ट्विस्ट हो जाता है क्योंकि तुम्हारा गूगली यहाँ पे ही पड़ गया था ना अल्कोहल का स्मेल देख के तुम लोग कंफ्यूज हो जाते हो कि वो अल्कोहल ओवरडोज हो गया इथाइल अल्कोहल ढूंढो नहीं इट इज ए केस ऑफ ओपियाइड ओवरडोज ओपियाइड ओवरडोज का ट्रीटमेंट क्या होता है ओपियाइड ओवरडोज का ट्रीटमेंट विल बी नैलोक्सोन ओपियाइड ओवरडोज का ट्रीटमेंट विल बी नैलोक्सोन द आंसर इज नैलोक्सोन वेरी गुड. Let's go to the next question. A 28-year-old man present to the infertility clinic because he has been 28-year-old man is okay present to the infertility clinic. So they're trying to conceive for the last 2 years without any success. His wife also getting evaluated. After evaluation, the man found to have increased serum level of hormone produced by acidophilic cells in the anterior pituitary gland. Given these findings, he prescribed a drug functional that is the direct receptor agonist. Which of the following disease could be used for? Wow. Now the problem here is that first you need to find out the disease. Second, you need to find out the drug. Third, you need to find out the second, you need to find out the first you need to find out the disease, then you need to find out the drug, then you need to find out the receptor, and then you need to think that which hormone is produced. First, let's break down simple. Okay. So simple baat kya hai? Here, they're trying to conceive means a couple is trying to conceive but 2 years without any success. His wife is found to be healthy, also getting evaluated. After evaluation, man is found to have an increased level of hormone. There is one hormone which is increased. Because of the increased hormone, the person is developing infertility. So the hormone increases and causes infertility in both male and female is prolactin. Prolactin is the hormone which causes infertility in both male and female. So prolactin is a hormone that is produced by the anterior pituitary gland. Okay. So now the treatment for this patient is what? Okay, treatment for this patient, if there is an increased level of prolactin, that will lead to inhibition of see in the female HPO axis, hypothalamo pituitary ovarian axis in the female, and in the male it will inhibit hypothalamo pituitary testicular axis in the male. So automatically there is a decreased level of testosterone, so that will lead to what? Decrease of spermatogenesis. Okay, so this is the story of your spermatogenesis. This is the story of your pathogenesis behind your prolactin. So the treatment for increased level of prolactin will be, my dear students, remember D2 agonist. The drugs which are used is D2 agonist. So D2 receptor stimulant. D2 agonist is also used. This drug also used in which disease? Also used in which disease? Also used in Parkinson disease, because in Parkinson disease there is a decrease of dopamine. So we can use drugs such as pamipexole, ropinirole, bromocriptine, cabergoline, which stimulate the D2 receptor directly in the brain for the treatment of Parkinson disease. But the D2 agonist such as bromocriptine, and as well as cabergoline. Both of these drugs are used for the treatment of your which disease? Very good. They are used for the treatment of hyperprolactinemia. So simple. All the end story is that they were not able to conceive for last 2 years. So his wife is also getting evaluated, but his evaluation revealed to have elevated level of some hormone, and that is causing him the infertility. That is high likely to be which hormone? That is high likely to be prolactin. So prolactin, if that is there, what is the treatment? D2 agonist will be given. So we can use bromocriptine or cabergoline. Now the question is when to use bromocriptine, when to use cabergoline. Remember, a cabergoline is the drug of choice if there is a prolactinoma is there. If there is a prolactinoma, means if you find a tumor which produce the prolactin level, then the drug of choice is cabergoline. If only elevated prolactin, means there is no tumor but prolactin is elevated, then the answer is bromocriptine. But if tumor is there, cabergoline is the drug of choice. If prolactinoma is there, then definitely the treatment is what? Definitely the treatment is your cabergoline. Clear? Understood everybody so far? Okay, let's go to the next one. A 59-year-old male present to his primary care physician complaining of a tremor. So first complaint is tremor. Let's write down the complaints. Okay, let's write down the tremors. Okay. So But first complaint is he developed tremor in his left hand approximately 3 months ago. Okay, it appears to be worst in the wrist. Diminishes if he points something or uses the hand to hold an object. Physical examination shows slowed movement. Physician decided to start the patient on a medication that prevents the degradation of a neurotransmitter. This medication also indicated for use in which condition? ओके अरे भाई क्या बात कर रहे हो तुम ऐसे ही लग रहा है तुम्हें नाउ लिसन टू मी फर्स्ट एंड मोस्ट ही इज हैविंग ए ट्रेमर at rest also he is having a tremor and he is having a movement issues so that is hypokinesia and resting tremor this is the resting tremor and also dyskinesia so the treatment for this condition the diagnosis is Parkinson disease right in the Parkinson disease we use multiple drugs such as for example MAO-B inhibitor okay then we also have COMT inhibitors right then we can also use levodopa plus carbidopa okay so in this question they are telling they prevent the degradation of neurotransmitter okay so they inhibit which of the two enzymes MAO and COMT these are the two enzymes which degrade which substance which degrade the dopamine now these inhibitors also used in which disorder okay so what will be your answer so remember I will tell you people I'll tell you very easily so what is that we have one important aspect we have dopamine and we also have serotonin okay dopamine and serotonin both of them are metabolized or degraded by an enzyme called as monoamino oxidase both of them are degraded by an enzyme called as monoamino oxidase if I inhibit this monoamino oxidase dopamine will be increased if there is an increase of dopamine so this will become the treatment of Parkinson disease and if serotonin is not metabolized automatically it will increase the serotonin if serotonin is increased so that will be the treatment of depression right so depression what is there selective serotonin reuptake inhibitor and norepinephrine reuptake inhibitor so what will be the drug that will be monoamino oxidase inhibitor that will be what monoamino oxidase inhibitors so monoamino oxidase inhibitors are also used in which disease all of us clearly know they can be considered in major depression got it मजा आ रहा है questions यार I'll be very honest okay I don't like to put in like very simplified questions जहां पे complicated questions see in surgery I had few simplified questions right I had some few simplified questions okay now also in surgery we had a simplified question because there were questions which were simplified in pathology we had simple questions but medicine is not like that we are trying to correlate everything in one place so understand the answer is what is the answer major depressive disorder ओके क्या कमेंट है चलो आगे बढ़ते नेक्स्ट क्वेश्चन हाँ एंड वन मोर थिंग थ्रू आउट दिस क्वेश्चन ऑफ दिस थिंग्स सी इन द एग्जाम दिस इज द हाईएस्ट लेवल ऑफ डिफिकल्ट ऑफ क्वेश्चंस यू माइट गेट ओके इससे ज्यादा कुछ नहीं हो सकता ओके सो दिस इज वन एडवांटेज फॉर यू पीपल ठीक है चलो देखते हैं A 42-year-old gentleman present to his primary care physician with the complaints of persistent headache, general weakness. Okay. Recently, he was diagnosed with a severe hypertension that has been refractory to antihypertensive medication. So, first point, patient is having a hypertension. Patient is having what? Hypertension. Now, patient is having hypertension and no response, and there is no response. There is no response for what? There is no response for the treatment. This is the case. Okay, based on the clinical suspicion you are a brilliant doctor what did you do you ordered some test okay you ordered some test what is that in that demonstrate serum sodium of 153 normal level of sodium is up to 146 so there is an increase of serum sodium okay And also potassium level of 2.9. Normal potassium level is 3.5 to 5.5 milli equivalents per liter. Very sensitive parameter. One time in exam they asked a direct question, what is the normal level of potassium? This is also an MCQ, that is 3.5 to 5.5 milli equivalents per liter or mg per deciliter, you can call it as. Okay, now he's having, what is that, elevated sodium level, elevated potassium level or decreased potassium level? Tell me very quickly. Decrease of serum potassium. Decrease of serum potassium. If serum sodium is increased, it will increase the water with it. If water is increased, automatically that will lead to increase of the blood pressure. Wow, ये कहीं तो देखा देखा लग रहा है. Very good, very good, very good. What is that? Increase of sodium and decrease of potassium is caused by which hormone? Aldosterone. Aldosterone. Which hormone? Aldosterone. So my question is that hormone is most likely cause of this patient presentation. It is normally secreted by which region of the adrenal gland? So they are asking aldosterone is secreted by which part of the adrenal gland? Okay, in the adrenal gland we have cortex. In the adrenal we have a cortex. In the cortex we have layers. So that is only called as GFR, out to in, out to in, from outside. Zona glomerulosa, zona fasciculata, zona reticularis. Okay, so what secretes what? GFR is the layers. GFR is the mnemonic for the layers. Okay, यहाँ तक सब लोग छोड़ देते, फिर आगे तुम कुछ जाके फंस जाते हो. You people will go and get stuck on it very easily because they gave you, wow, what a mnemonic, GFR. I will remember. GFR means glomerulosa fasciculata reticularis. But I am an examiner, I will ask you, glomerulosa produce what? Fasciculata produce what? Reticularis, fasciculata, glomerulosa. If I confuse you, you should not get confused. I will teach you one mnemonic here. Assistant general manager. If you take one company will have a general manager. Below him there will be assistant general manager. With him only I have created a mnemonic. AGM. GFR produces AGM. AGM. What is this AGM? Okay, A for aldosterone. A for aldosterone. A for aldosterone. Okay, G for glucocorticoids. Glucocorticoids. Okay, M for male sex hormones. Male sex hormones. Okay, so what is the which region of the adrenal gland is producing it? Zona glomerulosa fasciculata reticularis. Now at least give me an answer. So we found out that serum sodium is increased, potassium is decreased, that is caused by aldosterone. This is a classic scenario of Conn's syndrome. This is a classic scenario of Conn's syndrome. What is that? Conn's syndrome. What is Conn's syndrome? It is a primary hyperaldosteronism. Primary hyperaldosteronism. So there is an increased level of aldosterone. If there is an increased level of aldosterone, this will be the complaints to the patient. The answer is very good. That is your zona glomerulosa. Very nice answer. The answer is A, zona glomerulosa. So if Conn's syndrome is there, what is the drug of choice? What is the drug of choice for Conn's syndrome? Remember, the drug of choice is aldosterone antagonist. Aldosterone antagonist. Aldosterone antagonist. There are two drugs. We have aldosterone antagonist. एक है spironolactone. One is there spironolactone. One more is there eplerenone. One more is there eplerenone. Okay, if both of them are in the option, what to do? If both of them are in the option, what to do? This is the better drug. This is the better drug. Why? Because spironolactone has a side effect, that is gynecomastia. If it is a male person, if you give this drug, patient can get gynecomastia. So gynecomastia is absent for eplerenone. Gynecomastia is absent for eplerenone. So इसीलिए क्या करोगे? Eplerenone is the better drug. But if the eplerenone is not there in the option, go with the spironolactone. Will you solve this question? समझ में आ गया? तो देखो, now you understood. Adrenal gland produces what are the layers, what and all will be produced by where, and what is the effect of aldosterone, and what is the treatment for aldosterone. Like this you should learn. Let's go to the next question. A 54-year-old woman, हाँ मेरा बहुत मेहनत गया इसके अंदर. Don't take it for granted. A lot and lot of what is that? A lot and lot of hard work has been put in for creating this question. Okay, तो आप लोग मतलब बहुत अच्छे से इसको यूटिलाइज करो. जैसे ही नोट्स मिलेगा एक दो बार पढ़ लो ताकि तुम्हारा एंडोक्रिन बहुत सॉलिड हो जाएगा इसमें. A 54-year-old woman appears in your office for a new patient visit. Okay, she reports a past medical history of hypertension. She was told that it was related to the adrenal gland disease. You recall that Conn syndrome and pheochromocytoma both are the condition affecting the adrenal gland that result in hypertension, but by different mechanisms. Which area of the adrenal gland involved in Conn syndrome? Which area of the adrenal gland involved in the pheochromocytoma? Okay, let's see the answer. Okay, so Conn syndrome, first and most important. Let's basically break down. ध्यान से रश मत करो फियोक्रोमोसाइटोमा पूछा गया है. Don't rush. We have a Conn syndrome. We have a Conn syndrome. Conn syndrome is a condition where there is an increase of aldosterone. Increase of aldosterone matlab zona glomerulosa. Then we have pheochromocytoma. We have what is it? Pheochromocytoma. Pheochromocytoma means increase of adrenaline. Adrenaline. So increase of adrenaline and even noradrenaline means autonomic nervous system activity is increased. So adrenaline, noradrenaline is produced from the medulla of the adrenal gland. So adrenal gland is divided into adrenal cortex and medulla. From the adrenal medulla, you are getting what is that? Adrenaline, noradrenaline. Okay. Now, what is the treatment for Conn syndrome? What is the treatment for pheochromocytoma? What is the treatment? But before going into the treatment for the pheochromocytoma, the drug of choice is phenoxybenzamine. If you want to combine other drug, that will be propranolol, and in the Conn syndrome, that will be spironolactone. Now they are asking which area is involved. Which area is involved? So all of us know aldosterone is produced from GFR AGM. Okay, G for glomerulosa, A for aldosterone. So that will be zona glomerulosa. Zona glomerulosa is present in both the options. Okay, but they're telling what is that? Pheochromocytoma. Pheochromocytoma originate from where? Medulla of the adrenal gland. So the answer will be C, zona glomerulosa and medulla of the adrenal gland. Got the point? ओके चलो लेट्स गो टू द नेक्स्ट क्वेश्चन. देखो तुम्हें जहां जहां पे कंफ्यूज होगा, जहां जहां पे कंफ्यूज होगा वहां पे नोट भी डाला हुआ है मैंने. ठीक है, डोंट वरी. A 28-year-old patient comes to the physician office with the complaints of headaches and difficulty in seeing out of the corner of the eye. She gave birth to one son a year ago. Further visual testing reveals as bilateral temporal hemianopsia. The patient undergoes brain MRI which shows anterior pituitary mass, likely an adenoma. Patient had a blood tested. If adenoma is secreting extra hormone, the patient found to have a slight excess of the hormone, that is basophilic in stain. Okay, which of the following is most likely the hormone detected in her blood? Okay, मुझे पता था पोस्टमार्टम हेमरेज बोलते ही, पोस्टमार्टम हेमरेज तो दिया ही नहीं वहां पे. बर्थ दिया तो देने देना, ओनली पोस्टमार्टम हेमरेज causes Shihan syndrome. Right? You get the logic here. यहाँ पे there is no Shians. There is no Shians in this case. Why Shians? Now listen to me. Listen to me. What I'm trying to tell you is that I'm trying to tell you she is having bilateral temporal hemianopia. Bilateral temporal hemianopia. Hemianopsia. So bilateral temporal hemianopsia is a result of what? Bilateral temporal hemianopsia will be due to compression of what? Compression of optic chiasm. Optic chiasm. Optic chiasm compression के वजह से आता है bilateral temporal hemianopia. Okay, all right. अगर if there is a tumor in the gland, if there is a tumor in the gland, now we need to check. We need to check if there is any extra hormone. Okay. Now that takes up which hormone? Basophilic stain. Okay. Now listen to me. She is having what is that? She is having pituitary adenoma and basophilic stain. So what will be the answer? What will be the answer? So now the answer you need to understand. So what exactly is the hormone which is produced by the basophilic stain? That will be, my dear students, growth hormone. The answer is C. Okay. Okay. So that is the story of your what is that? Growth hormone. Basophil से आता है growth hormone. Acidophil से आता है prolactin and your TSH. Prolactin, prolactin and TSH. Both of these comes from acidophils. Both of these comes from acidophils. Okay, so in the brain, acidophils, basophils, neutrophils are there, like neutral cells are there. In that, acidophilic cells will produce prolactin and thyroid stimulating hormone, and basophilic cells will produce, that is your, what is that? That is your growth hormone. Okay. Now please listen to me. Basophilic cells will produce, that is your growth hormone. Okay. The answer is growth hormone. Very good answer. Okay. चलिए आगे बढ़ते हैं next question. ठीक है. A 19-year-old college student is brought to the emergency department by his roommates after being found unconscious in their dorm floor. His temperature is 38.9 degrees Celsius. Blood pressure is 86 by 64. On physical examination, he has a multiple rose-colored spots on the skin covering his abdomen and lower limb. His lab test revealed hyperkalemia and arterial blood gas analysis reads pH is 7.4, pH is 7.4, PCO2 is 30.1, okay, and PO2 is 23.4. Okay, what is the most likely diagnosis for this patient? Okay, तो बताओ बताओ आंसर बताओ, मुझे देखना है आंसर. First, patient is having acidosis. Patient is having acidosis, and one more thing, he is having hyperkalemia. Hyperkalemia. ठीक है. हाँ, कनेक्ट द डॉट्स, आराम से कनेक्ट करो यार, कोशिश करो. तुम तुक्का मारो, ये क्या हो सकता है, कौन कौन मना कर रहे हैं, बताओ बताओ बताओ. आई वांट आंसर्स. Okay, one very good effort, that is answer is B. Okay, but I will give the confirmation of answer and I will make you people tell the answer. Okay, tell the answer. Come on. यार इतना भी नाराज मत करवाओ यार, कमेंट तो डालो, गेस तो करो, ये बी सी डी तुक्का तो मारो. जब एग्जाम के अंदर जब आंसर पता नहीं होता है, तुक्का तो करोगे ना. चलो. Acidosis, hyperkalemia is there in the patient. Along with acidosis and hyperkalemia, there is multiple rose color spots on the skin and abdomen. Okay. So there is a rashes on the abdomen and also abdomen and also lower limb. Abdomen and also lower limb. Okay. Now, one more thing, what I'm trying to tell you people here, please listen to me, please listen to me. And also there is a decrease of the blood pressure. ये कहीं से तो मुझे तो नहीं लग रहा है डेंगू हेमोरेजिक फीवर, डेंगू शॉक सिंड्रोम और डेंगू हेमोरेजिक फीवर का कहानी कुछ अलग होता है. Okay. So it is not Addison disease also. Okay, because Addison disease has no rash. Addison disease has no rash. Rest everything will be there, no rash, but patient will have abdominal pain. Okay, then patient will also have acidosis. Okay, decrease BP, and also hyperkalemia. Okay, so that is the point here. No, A is not an answer. A is not the answer. A is not the answer because Addison disease has no rash, but here patient has a rash. Okay, so the answer is diabetic ketoacidosis. हो ही नहीं सकता. Only acidosis is there, rest everything. Dengue hemorrhagic fever, no, it is not a dengue hemorrhagic fever because there was no history of dengue. Okay, or any other these things. Okay, and they're very clearly telling you about what is. It's not Addison disease. There is no rash, my dear. The answer is D. Waterhouse-Friderichsen syndrome. Waterhouse-Friderichsen syndrome. Okay. Waterhouse-Friderichsen syndrome. What is this Waterhouse-Friderichsen syndrome? This is a disease. It is caused by meningococcal sepsis. Okay. So what happens? All of you know, very good answer. Answer is D. So listen to me. What is that? Meningococcal sepsis. क्या होता क्या है meningococcal sepsis? Now please, if you listen to me very carefully, meningococcal meningitis is a red bacteria. Now listen to me very carefully. Now I'm speaking. Okay, now am I audible clearly? Just let me check here, because with my phone it is giving proper response. Okay, now listen to me very easy. So we have a bacteria called meningococcal meningitis. Meningococcal meningitis, this bacteria comes into the body. It can affect meninges leading to meningitis. Now it's fine, right? Meningitis. Okay. Now, the next important point here. Now, listen to me. What is that? There is one problem. What is that? Meningococcal meningitis. And the problem is that meningococcal sepsis, if the bacteria end up in the bloodstream, then what will happen? If bacteria end up in the bloodstream, now what is going to happen is, now it will cause bleeding in the internal organs. What will it cause? Bleeding in the internal organs. internal organs. If there is a bleeding in the internal organs, that can also cause bleeding in what is that? Adrenal cortex. Bleeding in the adrenal cortex. If there is a bleeding in the adrenal cortex, if there is a bleeding in the adrenal cortex, now adrenal gland is not working, that will lead to decrease of the cortisol. If there is a decrease of the cortisol, that will lead to what? That will lead to increase of potassium, and also it will also lead to decrease of sodium. This is also a point to remember. Decrease of cortisol and also decrease of aldosterone. So there is a bleeding in the adrenal cortex, because of which all these things will happen. Sir, how do you know it is a meningococcal sepsis? Why not? This is what is that? This is what is Addison disease. Remember, meningococcal sepsis will cause rash in the abdomen. Okay, and the shape of the rash will be star shaped. It is going to be a star shaped rash. Okay, and also what is going to be there? Star shaped rash, and central necrosis will be there. So this is the story of Waterhouse Friderichsen syndrome. Okay, now we got my point, everybody. Now listen to me. Let's look at the pH here. Okay, by looking at the pH, sir, how to solve about this ones also. I will teach you people about the pH part also. Don't worry, I'll teach you people. First, let's finish this MCQs. Okay, now a 27-year-old Caucasian female presents complaining of recent weight loss. She's having a weight loss. Very good. And also she's having a weakness. She reports that she feels dizzy and lightheaded every morning when she gets out of the bed, and often work at whenever she must rise from her desk. Okay, she is having dizziness whenever she is changing the position. So she is having orthostatic weight loss. Let's write down the complaints. Weight loss, orthostatic hypotension. Okay, and also, my dear students, their physical examination reveals several areas of skin, including her elbows and knees have more pigmented than the other areas. So she is having a hyperpigmentation. Which of the following would be consistent with this patient's disease? I will not ask the diagnosis. Now what can you find in this diagnosis? Tell me the answer. Somebody, okay, you're telling answer is B. Any other answer? So let's look at understand first thing. Weight loss, orthostatic hypotension, and hyperpigmentation. These are a classic symptoms of Addison disease. What is that? Addison's disease. So what happens in the Addison's disease? I will tell you people. So when you're talking about a Addison disease, we are talking about a Addison disease. Now Addison disease, what happens, my dear students? Please remember, you people are absolutely correct. The answer is correct. That is B. Okay, B. The patient is going to have hypoglycemia. Why? That also I will tell you. Okay. Now listen to me. Addison disease. What happens is that adrenal cortical insufficiency. Adrenal cortical insufficiency means what I'm trying to tell you. Adrenal cortex is not working properly. If adrenal cortex is not working properly, that will lead to what? Adrenal cortex is not working properly. Now that will lead to increase of ACTH. Anytime if there is an increase of ACTH, blindly remember there will be increase of MSH also, especially in Addison disease. But if it is ectopic ACTH, in the lung cancer ACTH, that is totally different. But in a normal physiological case, if there is an increase of ACTH, there will be increase of MSH. If more MSH, that will lead to what? Hyperpigmentation. So in the Addison disease, increase of ACTH, increase of MSH, and remember, if adrenal cortex is not working properly, automatically there is a decrease of sodium in the blood and increase of potassium in the blood. Okay, so remember, the aldosterone activity will be reversed in the Addison disease. Simple as that. Aldosterone activity is reversed in the Addison disease, so patient will have hyperkalemia. Okay, now if more of cortisol, more of glucose, patient would have hyperglycemia. But here there is no cortisol. If there is no cortisol, that means glucose level will be less. Actually, in this patient, what and all you are going to get is hyperkalemia, hyponatremia, okay, hypoglycemia, okay, And also patient can have acidosis. Patient can have acidosis. So these are the metabolic changes which can be found in patient with Addison disease. Addison disease. Okay. And remember, there is a weight loss, not weight gain. Weight gain is a symptom of which disease? Cushing disease. Adrenal gland. Every adrenal gland disease does not mean weight gain. Remember this point. Here it is a weight loss in this patient. It is going to be a weight loss in this patient. Definitely, I will share the PDF in the description of the video. There is a link there. You can find the PDF as well. Not an issue. Okay. Now it will be uploaded at the end of the discussion. Okay. Now let's go to the next question. What is the next question? So a 34-year-old Caucasian female. So before going there, I will teach you people Addison disease in a quickly nutshell in 1 minute. Please listen to me. Addison disease is a disease in which adrenal cortex is not working. If adrenal cortex is not working, aldosterone and also glucocorticoids, both of them are not produced. That will lead to chronic adrenal insufficiency. If there is adrenal gland is not working, your body will try to stimulate it by producing ACTH. If ACTH is more, automatically melanocyte stimulating hormone will also increase, because both of them come from one compound called as POMC, pro-opiomelanocortin. Okay, so both of them are coming from the POMC. If there is an increase of ACTH, there is an increase of MSH. So because of that, hyperpigmentation will be there. Since there is low level of aldosterone and cortisol, what will happen? Normally, aldosterone, if it is there, it used to retain the sodium. Now aldosterone is not there, so it will send the sodium out of the body, leading to decrease of the sodium, hyponatremia and hyperkalemia. Okay, acidosis and weight loss, these are the symptoms of Addison disease. So before we finish Addison disease, tell me one simple thing. What is the treatment? Steroids are not there. Give the steroids. What is going to give? You are going to give corticosteroids. You are going to give corticosteroids. If it is an acute scenario, IV steroid. If it is a long-term management, oral steroids, usually long-acting like dexamethasone and betamethasone. समझ में आ गया? Everybody understood? Okay, let's go to the next question. What is the next question? A 34-year-old Caucasian female presents with a truncal obesity, rounded moon face, and a buffalo hump. Okay, serum analysis shows hyperglycemia. It is determined that pituitary adenoma is the cause of the adrenal. The cause of these symptoms, adrenal examination is expected to show. बढ़िया, 12th is pushing, right? Disease है कि नहीं है? ये पहली question number 1. You are trying very good. Okay, question number 1. And question number 2 is that I'm going to have you one simple question, that is, what can you find in the adrenal gland? Atrophy of the adrenal medulla. अच्छा, क्यों? Adrenal medulla से ACTH का कुछ लेन देन नहीं है. Cushing syndrome? No, it is not a Cushing syndrome. हाँ, और बताओ, ऑप्शन में देख के बताओ, what can you find? यार यहाँ तक तो बढ़िया था. डायग्नोसिस पूछे होते, वी वुड हैव टोल्ड ईदर कुशिंग सिंड्रोम और दिस. आप क्यों पूछ रहे हो कि इन पैथोलॉजिकली एड्रेनल ग्लैंड के अंदर क्या होता है? अब वैसे ही तो सीखेंगे. सो लेट्स अंडरस्टैंड. ना ना ना, ये फियोक्रोमोसाइटोमा है ही नहीं. ये मेडुला के साथ कुछ लेन देन नहीं है क्वेश्चन में. अरे क्या हो गया यार तुम लोगों को? इतना सडनली पार्टी क्यों बदल रहे हो? फियोक्रोमोसाइटोमा में क्यों जा रहे हो? व्हाई आर यू गोइंग टू फियोक्रोमोसाइटोमा? व्हाई? हाँ, आंसर इज बी. नाउ लेट्स स्टार्ट. फर्स्ट एंड मोस्ट इंपॉर्टेंट, we have Cushing's is there. Cushing's is there. In Cushing's we have two problems. One is Cushing's syndrome, and one more is Cushing disease. One more is Cushing. Okay, so we have two things, Cushing disease and Cushing syndrome. In Cushing syndrome, the pathology means the problem is located where? Either we get a ectopic ACTH means normally ACTH is produced from the pituitary gland. Apart from the pituitary gland, if any other place produces ACTH, we call it as a ectopic ACTH. That can be seen with small cell carcinoma of the lung. And also that can be due to adrenal cortex itself. Adrenal cortex means there is a adrenal cortex on its own. If there is a tumor in the adrenal cortex, the tumor itself on its own, it is producing a lot of cortisol. Then we call it as a Cushing's syndrome. What is Cushing disease? Cushing disease, always the disease associated with the pituitary gland. So what exactly happens here is that pituitary adenoma that will lead to increase of ACTH production. If there is an increase of ACTH production, that will lead to increase of cortisol. So in Cushing's, if you call it as a Cushing's, automatically cortisol will be increased. If more cortisol, that will lead to what? That will lead to moon-like face, buffalo hump. Okay, along with that, in the serum, in the blood. So if there is an increase of cortisol, there is an increase of cortisol, right? If there is an increase of cortisol, what and all you can find in the blood vessel? First and most, increase of sodium, decrease of potassium. Okay, and also increase of glucose. Okay, and also decrease of WBCs. Okay, patient will also have peptic ulcer disease. Patient will also have osteoporosis. Now all these symptoms are common for both Cushing syndrome and Cushing disease. For both of them it is common, but what is the difference between the disease and syndrome? There is an increase of ACTH. If there is an increase of ACTH, this ACTH will stimulate which area? Adrenal cortex. Adrenal cortex will undergo what? It is a glands will undergo hyperplasia. So what you are going to find, if there is an increase of ACTH, so diffuse hyperplasia of the adrenal cortex. Diffuse hyperplasia of the adrenal cortex is what you can find in the patient with Cushing's disease. You got the logic? So pura Cushing disease and syndrome, in 1 minute I will tell you, people listen to me very carefully. What exactly is the problem? Cushing disease and syndrome, in both of them, cortisol is increased. Cushing syndrome is the problem whether ectopic ACTH or pathology with the adrenal cortex, then we call it as a Cushing syndrome. If the disease coming from the pituitary gland due to increased ACTH, always we call it as a Cushing disease. In the Cushing disease, ACTH is increased, that will increase the cortisol by causing diffuse hyperplasia of the adrenal cortex. Point number 1. That is your Cushing syndrome and disease. In both Cushing syndrome and disease, we have this following symptom: increase of sodium, decrease of potassium. More sodium means hypernatremia, more water. See, addition mein less sodium because cortisol was not there. Here more sodium because cortisol is more. Okay, then the patient will have hyperglycemia. Okay, decrease of WBC, recurrent infection because they reduce of WBC. Patient will have peptic ulcer disease, osteoporosis, and also fat redistribution, round face, moon-like face, buffalo hump, android obesity, and also purple color. They are not stretch marks, but also called as purple striae on the abdomen. So these are the things which you can find in a patient with the Cushing disease and syndrome, both of them. Okay, now you might ask me, sir, what is the treatment? Always we can use one drug called as ketoconazole. The mechanism is not clearly known how antifungal drug works here. Ketoconazole can be considered, but the best treatment is remove the trigger. If adrenal cortex has a tumor, remove the tumor. If pituitary has an adenoma, remove the adenoma. If small cell carcinoma of the lung is there, treat the small cell carcinoma of the lung. So treat the cause is the best strategy. You got it completely? Cushing syndrome adds a pura adrenal gland. Now you understood. Now let's go to the next question. Let's see how much you understood. Okay. A 37-year-old man presents to the clinic for a 2-month follow-up. 2 months follow-up के लिए आया था. Okay. He is relatively healthy. Okay. Except for 5-year history of hypertension. He is currently on lisinopril, amlodipine, and hydrochlorothiazide. He is taking 3 antihypertensive medications. Laboratory testing demonstrate elevated plasma aldosterone concentration and low renin concentration. What is the most likely underlying explanation for this patient? Let's see. Okay, what is the underlying cause? भैया क्वेश्चन ही मतलब अगर हम वापस आएंगे, ऐसा क्वेश्चन आ गया, वापस आने के बाद रिकॉल भी नहीं कर पाएंगे. अरे ऐसा कुछ नहीं है. आप एक बार एक्सप्लेन करूंगा. आफ्टर आई एक्सप्लेन दिस, लेट्स सी हाउ कैन यू नॉट रिकॉल दिस. आई विल टीच यू. लिसन टू मी वेरी केयरफुली. He is taking 3 medication: lisinopril, amlodipine, hydrochlorothiazide. Still he is having a elevated level of No, D is the wrong answer. Okay, elevated level of blood pressure. Laboratory shows that increase of aldosterone and also decrease of renin. Here is the catch. Increase of, no, D is not the answer. Okay, increase of aldosterone and decrease of renin. So if there is an increase of aldosterone and decrease of renin, let's see. So remember, you have RAS system. You have RAS system. Okay, RAS system will produce aldosterone. One mechanism for aldosterone. Okay, what is that? Very good. The answer is A. So first answer is, what is that? Answer is A. But one mechanism, RAS will produce aldosterone, and aldosterone production can happen independently also. Okay, independent also means aldosterone can be produced on its own. Aldosterone can be produced on its own. If there is a high aldosterone, it will inhibit the RAS system. It will inhibit the RAS system. If RAS system is inhibited, there will be decrease of the renin level. 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 So if aldosterone is coming from independently, means there should be a tumor which is producing what? Producing aldosterone, producing adenoma. So there is a tumor which is producing what? Aldosterone. That aldosterone is only producing, inhibiting the renin production. Now what is this D, sir? Sir, the D is your Bartter syndrome. D is what? Bartter syndrome. Bartter syndrome. What is Bartter syndrome? Bartter syndrome is a mutation of sodium potassium 2 chloride transporter. That is your Bartter syndrome. That is your Bartter syndrome. Okay. Now, this is a story of your question number 13. Can I go to the next question? The answer is A. Let's go to the next question. A 40-year-old female complains of muscle weakness. Her blood pressure is 180 by 140. Oh my God, BP is increased. Point to be noted. And serum potassium is 3.2. So there is a decrease of potassium level. Very nice. Okay. And plasma renin levels are abnormally low. So there is also decrease of renin. Okay. And a CT scan of abdomen revealed 3 centimeter lesion on the adrenal gland. Means they did a CT scan in the adrenal gland. They found a tumor. Unannotated PDF, I have that, but I can share it only after the class is done, because that is in a different devices. I really can't access this. Just to do one thing, you just listen to the explanation. Okay, I'll give you the annotated notes. During the revision, into that only you can add the points. Okay, I'm really sorry if I didn't think of this. Okay, I'm sorry. So if you want, you can just when you're revising, you can watch the video or something, because if I would have thought that I could have sent it to people. Okay, sorry for that. Now there is a decrease of potassium and decrease of renin. If there is a decrease of potassium and decrease of renin, and also patient is having what? A tumor in the adrenal gland, and increase of BP, increase of BP. If there is an increase of BP, means there is an increase of sodium. If there is an increase of sodium, that will lead to increase of water. Okay, if water is increased, that will increase the blood pressure. Okay, wow, this is very nice. This is a tumor. Tumor is producing what? Tumor is producing aldosterone, because more sodium, less potassium, and less renin. Aldosterone comes from where? Zona glomerulosa. Zona glomerulosa. Okay, now ऐसा चीज कट करके कई memes मत बनाओ, ठीक है? So what is that? Zona glomerulosa. Good, good. You got the logic now? Okay, let's go to the next question. Okay. A 34-year-old woman comes to the emergency department complaining of severe headache and anxiety. Okay. And palpitation for the last 30 minutes. She had several similar episodes over the past few weeks. Her blood pressure on the arrival is 181 by 80. Okay. Her pulse is 134. If patient was given a propranolol, how would her blood pressure respond? Let's see. सर पहले तो ये बताओ, ये क्वेश्चन में डायग्नोसिस क्या है? आप प्रोप्रोनॉल कहाँ से पकड़ के लाते हो? क्या कर रहे हो आप? है ना? So सुनो, very simple. So she is having palpitation, anxiety, and also severe headache and elevated blood pressure. So remember, this is a classic presentation of pheochromocytoma. It's a classic presentation of pheochromocytoma. pheochromocytoma. Pheochromo what? Cytoma. This is a classic representation of pheochromocytoma, and heart rate is also increased. So in the pheochromocytoma, what happens? There is an increased level of adrenaline. There is an increased level of now what he is asking is that if the patient was given propranolol, if they give propranolol, what will happen? So if there is an increase of adrenaline, what will happen? Let's see. Now I will give a propranolol. I will give a propranolol. So if I give a propranolol will block the beta 1 receptor, and as well as propranolol will block the beta 2 receptor. So if propranolol blocks the beta 2 receptor, now adrenaline, where it will see? Normally adrenaline will go and stimulate alpha 1 as well as your beta 1 and beta 2 receptor. Okay, alpha 1, alpha 2, beta 1, beta 2 receptor. So adrenaline will stimulate all the 4 receptors. Okay, so what is that? All the 4 receptor. Now what am I doing? I am blocking these 2 receptor, beta 1 and beta 2. Now adrenaline, so if I'm blocking these 2 receptor, that means adrenaline can only act on what? Alpha 1 and alpha 2. If it can act on only and alpha 1 and alpha 2, what can happen? So alpha 1 receptor causes vasoconstriction. Vasoconstriction means increase of the BP. So patient will have even more elevated blood pressure, hypertension due to alpha 1 adrenergic. One second. Okay, how would the blood pressure respond? Okay, so patient will have hypertension due to what is that? Due to alpha 1 receptor stimulation. The answer is D. The answer is D. Okay, the answer is D. तो नॉर्मली यहाँ पे दो क्वेश्चन सॉल्व करवाया. इन द प्रेजेंस ऑफ अल्फा ब्लॉकर एड्रेनालिन दोगे. यहाँ पे दो पॉइंट आते हैं, दोनों पॉइंट बहुत अच्छे से देख लो, नोट दिस बोथ पॉइंट्स. इन प्रेजेंस ऑफ अल्फा ब्लॉकर, इन द presence of alpha blocker, in the presence of alpha blocker, if adrenaline is given, then you are going to get a hypotension. In the presence of propranolol, that is beta 1 and beta 2 blocker, then you are going to get a elevated level of blood pressure. So answer will be D, my dear students, not D. Hypertension, not hypotension, hypertension. Okay, chalo, let's go to the next question. See, I am trying to revise the whole endocrinology here, so that is why you people will feel little difficult. Okay, now, a 53-year-old woman presents to the clinic with the... See, my dear students, I'm telling you again, this much complicated questions will not come up in your FMGE. So, sir, why are you doing it 2-3 days before? Because 2-3 days before, so that you can completely revise the whole topic itself. Now, if I tell you this, you understood almost 60% of the pheochromocytoma here. You understood more than 70 to 80% of your, what is that? Conn syndrome, Addison disease, and also Addison Cushing disease and Cushing syndrome. So that is the reason why I got these questions. Okay. Okay. Thank you. Let's continue. Let's continue. Okay. So what I'm trying to tell you next, go chalte agle. A 53-year-old woman presents to the clinic with complaints of fatigue. She reports that over the past several months, she has been lethargic and tired. She has gained 10 kg, okay, but attributes to her menopause, her last menstrual period 1 year ago. Review of the symptom is negative except for cold intolerance and constipation. What is the next? What is evaluation? Okay, so very simple funda. What is the simple funda? Simple funda is what? She is having weight gain, okay, then she is having cold intolerance, and also she is having constipation. Okay, constipation. Okay, so when we are talking about this constipation, so this is suggesting me that of what is that? Hypothyroidism. Most common cause of hypothyroidism. Earlier we used to say, what is that? Very good, all of you are absolutely right. Okay, perfect, the answer is C. Okay, now listen to me. Why? So hypothyroidism, most common cause. Earlier we used to say in India iodine deficiency. Right now iodine deficiency is not seen because we have a iodized salt. Okay. Now most common cause is Hashimoto thyroiditis. So Hashimoto thyroiditis. What exactly is happening? Hashimoto thyroiditis is due to what? antibody titer. What is that you are going to check? Thyroid peroxidase antibody, because in the Hashimoto disease there is something called as TPO antibodies, in which destruction of the thyroid glands will occur. Okay, so that is the story of your what is that thyroxine peroxidase antibody. Okay, confuse मत होइएगा, TSH level check कर सकते हो. Okay, but the thing is that most specific for hypothyroidism would be your thyroid peroxidase antibody titer level, most specific. ठीक है, अगर if TPO antibodies are not given, then you can go for TSH and T3 T4 level. In this case, what you are going to do, you are going to do a thyroid profile TSH T3 T4, and next step you are going to do is hypothyroidism. When you already know, next step you are going to do is TPO antibody in the step of diagnosis, then go for diagnosis. Okay, now what is the treatment? Treatment will be what? If the patient is having hypothyroidism, the hypothyroidism treatment will be what? ट्रीटमेंट प्रोफाइल थायरोसिल दोगे क्या हाइपोथायराइडिज्म को? नहीं, हाइपोथायराइडिज्म को लीवोथायरॉक्सिन दोगे. व्हाट इज दैट? लीवोथायरॉक्सिन. लीवोथायरॉक्सिन is an analog of T4. Okay, nowadays we have a newer drug that is called as leothyronine, that is an analog of T3. It is used only for the emergencies, which is not currently used in India that much, but they might ask you a question since it is a newer medication. Okay, let's go to the next important. A 37-year-old man present his primary care physician because he had a constipation for last several weeks. He also been feeling lethargic and complains that this winter has been particularly cold. Means he's having cold intolerance, lethargy, constipation. Same complaints as previous case. He also complains that he has been gaining weight. Okay, weight gain. Okay. He reveals that 2 months prior to the presentation, he had felt what like flu, for which he took Tylenol and did not seek a medical attention. Several days after this developed anterior neck pain. Which of the following would be most likely seen on the biopsy of the patient? Okay, now listen to me. This is a question which is combined from surgery, and मतलब ये मत बोलना कि सर ये FMG में कब आया. भाई बार बार आया हुआ है, बस थोड़ा आगे पीछे करके. Now listen to me. He is having a history of flu, and followed by that hypothyroidism. hypothyroidism hypothyroidism hypothyroidism. So if the followed by that, if he is having a hypothyroidism, so what happens after flu? If there is a hypothyroidism, remember this is a direct case of decuvariant thyroiditis. Open your surgery notes, it will be written decuvariant thyroiditis. Okay, now decuvariant thyroiditis is also called as granulomatous thyroiditis, which is a decuvariant thyroiditis, also known as granulomatous thyroiditis. Okay, very good. The answer will be, you are going to find D, that is your granulomatous inflammation. Okay, now in the thyroid gland, if you find fibrous tissue, in the thyroid gland, then we call it as a Riedel's thyroiditis. So there is a fibrosis, thyroiditis. There is a fibrosis. Fibrosis means connective tissue formation. If connective tissue means it is a solid tissue. If you palpate the neck of the patient, you'll feel like as if you are palpating some wood because of the hard thyroid gland. So that is the story of your what is the Riedel's thyroiditis. Okay, let's continue to the next question. Okay, so what exactly is this? Okay, a 44-year old male complains of carpopedal spasm and perioral numbness. My dear students, the rule number 1 is very simple. Carpopedal spasms. That is carpopedal spasms. That is a clear-cut indicator of hypocalcemia. कुछ मत सोचो, ज़्यादा मत सोचो. Carpopedal spasms means hypocalcemia. Okay, hypocalcemia's clinical feature I will highlight. So carpopedal spasm, perioral numbness, and paresthesia of hand and feet. Past surgical history significant for thyroidectomy. If you do a thyroidectomy, while removing the thyroid gland, you might also remove parathyroid gland. Okay, total thyroidectomy. Then realized all of these symptoms occurred after the surgery. Following would be present in this patient. So see, remember the signs of hypocalcemia are two things. There is something called as Chvostek sign Chostexine and carpopedal spasm. Carpopedal spasm. These two are the signs of, these two are asked previously, these two are the signs of hypocalcemia. Okay, so in all of these patients will have a hypocalcemia. Now parathyroid gland is removed. If parathyroid gland is removed, what will happen? So you are going to have chostexine, so all of them will have a chostexine here. Okay, then let's look at the next important. There is a decrease of parathyroid hormone level. So decrease of parathyroid hormone. Okay, and also if parathyroid hormone is less, automatically decrease of serum calcium. So decrease of serum calcium and increase of phosphate and QT prolongation. The answer is D. So what exactly hypocalcemia? Overall, I will tell you hypocalcemia is due to what? One of the major causes is when you're doing a thyroid surgery, you remove the parathyroid gland also. That time there is no parathyroid hormone. If no parathyroid hormone, serum calcium is reduced and also increase of serum phosphate levels. If there is an increase of serum phosphate level, decrease of serum calcium, decrease of parathyroid hormone, so patient will have complaints such as carpopedal spasm, perioral numbness, feet, paresthesia of hand and feet. Even he can complain of what is that? Spasm of the lower limb muscles. Okay, all of these things will be there as a clinical feature. So what exactly you are looking at here? The looking here is chostexine QT prolongation, decreased the parathyroid hormone, decreased serum calcium and increased serum phosphate. So this is a complete story of your parathyroid hormone in one question. Done. Jobs. Simple. Now what I'm trying to tell you, the next important, sir, इसको treatment क्या करें भाई? Treatment is very simple. Immediately, if there is a severe hypocalcemia, then what will you do? Severe hypocalcemia, if you live like that only, he might get seizures and die also. Severe hypocalcemia, you are going to give IV gluconate, okay? And mild hypocalcemia is there, then what you are going to do? Yes, vitamin D3 plus calcium. Done. Let's go to the next question. A 32-year-old woman presents to her primary care doctor complaining of increased fatigue, okay, and cold intolerance and her recent delivery. After her recent delivery, so she gave birth to a baby. After that, she is developing fatigue and chostexine and trasucide. Okay, so fatigue and also she is having what is that? Cold intolerance. The patient delivered a healthy 39-year-old by 3 weeks ago via spontaneous vaginal delivery. Thank you. Spontaneous vaginal delivery. The delivery was complicated by PPH. तभी बोल रहे थे ना, अब बताओ PPH हो गया था. PPH will lead to postpartum hemorrhage, will lead to what is that? Postpartum hemorrhage. PPH was there. PPH will lead to one problem called as Sheehan's syndrome. What is the name of the disease? Sheehan's syndrome. What is Sheehan's syndrome? You know? What is Sheehan syndrome? You know, Sheehan syndrome is nothing but anterior pituitary necrosis. If there is anterior pituitary necrosis, there is no FSH, there is no FSH, there is no LH, there is no TSH, there is no TSH. So what will happen? Let's see. Okay, which of the following serum laboratories may be expected? FSH increased, increase glucocorticoids, decrease, the most important for her symptoms, the most important, most relatable answer is decrease of thyroid hormone. But the answer is not that also, because here thyroid releasing hormone, so the best answer is what? There is a decrease of prolactin, because thyroid releasing hormone TRH is produced from hypothalamus. Okay, so it's produced from hypothalamus. So there is no increase of FSH, and if there is also no increase of glucocorticoids, answer is prolactin, decrease in prolactin. So that is why the patient's first clinical feature, failure of lactation will be the first clinical feature of a Sheehan syndrome. Okay, let's go to the next question. A 32-year-old, okay, a 32-year-old female presents to her obstetrician 3 weeks postpartum for the failure to lactate. Of note that she has been unable to tolerate cold environment since the gave birth to child. The review of symptom is positive for fatigue and lightheadedness. Her delivery was complicated by placenta accreta with a postpartum hemorrhage. On the panel of hormone testing, which of the following will be normal in this patient? हाँ, बताओ तुम लोग बताओ. बताओ. यार बहुत सिंपल है. शी इज हैविंग पीपीएच. आफ्टर पीपीएच TSH is not there. If TSH is not there, most likely normal. It cannot be normal because TSH is not there. TSH will be reduced. Okay. Anterior pituitary is gone. Luteinizing hormone is also reduced. Okay. If there will be decrease of ACTH because anterior pituitary is gone. No ACTH. Cortisol will also be decreased. But which is not under the influence? Aldosterone. Answer is A. Aldosterone is not under the influence of, not under the influence of what? Influence of pituitary gland, not under the influence of pituitary. समझ में आ गया? The answer is A. The answer is A. Okay. So let's go to the next question. The next question is the, okay. So a 34-year-old woman presents to her obsgyne with the complaints of missing her last 3 periods as well as intermittent spontaneous milky white discharge bilaterally for past 3 months. UPT is negative. Now notice here, my dear students. So she is having what is that? Discharge, milky discharge from the nipple. But UPT is negative. UPT is negative means she is not pregnant. So if she is not pregnant, there is no milk production logically speaking. But still she is having a milk discharge. Okay, which of the following sets of laboratory result would be expected in this patient? Okay, so what exactly milky white discharge? That is clearly telling you. So she is having amenorrhea. Amenorrhea means loss of or absence of periods is there. Very good. Okay, and she is having what is that? Galactoria. Galactoria. Okay, galactoria, and UPT is negative. So this is a clear-cut sign of what is that? Increased level of prolactin. If prolactin is increased, what it will do? Prolactin will give negative feedback for GnRH. If GnRH, if negative feedback is there, reduce of GnRH. If reduce of GnRH, it will reduce FSH and also it will reduce LH. So the answer is increased prolactin. Both of the B and C can be correct, but decreased FSH and decreased LH. The answer is C. So let me check who all gave the answer. Very good, you people are absolutely correct. The answer is C. चलिए आगे बढ़ते हैं to the next question. ठीक है? Still we have many questions. Do you want me to do, or they are getting very difficult? If they are getting very difficult, we can just cut down these questions and go to other parts. I can just quickly review the disease names and go off. Your wish. Okay. So till you give the answer, I'm going to the next question. Okay. A 29-year-old female visits her gynecologist because of inability to conceive with her husband. Past medical history reveals that she has been amenorrheic for several months. She complains of frequent nipple discharge. Urine test for beta HCG is negative. Receptor agonist of what should be given? I just thought you, please, yes, thank you. Let's look at the answer. Please look at the answer. Please look at the question. So she is having amenorrhea. She's having amenorrhea, nipple discharge. So she is high likely having what is that? Prolactinoma. She's high likely having that prolactinoma. Prolactinoma treatment is what? Treatment is D2 agonist. D2 agonist. D2 agonist. So the answer will be what? D2 agonist. Dopamine receptor should be stimulated. The answer will be B, dopamine. Would be most likely to treat a condition. We are trying to stimulate. What is that? Stimulate the dopamine receptor, not vasopressin. Dopamine is also called as a prolactin inhibiting hormone. Okay, so if there is an increase of dopamine, automatically there will be decrease of prolactin. समझ में आ गया? Decrease of prolactin. Okay. A 30-year-old man present to your clinic complaining of excessive thirst and frequent urination for the past few months. The urine testing revealed low urine osmolarity, which failed to increase after subjecting the patient to water deprivation test and injection of desmopressin. Further into encounter, the patient reveals that he had a mood stabilizer, bipolar disorder, several years. Which of the following is the most likely cause of this patient? Okay. If you don't know answer, now you need to understand one simple technique. I'll teach you people. Lithium was used. Lithium was used for a long period of time. Okay. Lithium was used for a long period of time. Okay. For several years. Okay. So if there is a several years, very good, Dr. Medicos. So lithium side effect is what? Nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. The answer is B. But sir, ऐसा तो हम भी मानेंगे नहीं. आप तो रिवाइज कराओ. You are correct. B is the correct answer. आप रिवाइज कराओ कि पूरा diabetes insipidus. Remember, diabetes insipidus. Diabetes insipidus is a condition where there is polyuria is there. Polyuria, and also polydipsia. Okay. Now here it can be of two types. One is nephrogenic, one is central. In the central, what happens due to any problem like trauma? Okay, due to any problem like trauma, for example, craniopharyngioma, due to anything, there is a decrease of ADH. So if less ADH, so what will happen? Decreased reabsorption of water. Decreased reabsorption of water. If there is a decreased reabsorption of water, loss of water will be there. If loss of water will be there, urine becomes diluted urine. If diluted urine is there, so that will be called as increase of osmolality. ये पॉइंट ध्यान से देखो, ऑस्मोलैलिटी इज इंक्रीज्ड इन द यूरिन. ओके सर, ऑस्मोलैलिटी क्या होता है, लैलिटी क्या होता है? यार कुछ नहीं यार, सिंपल सी बात है. एक सॉल्यूशन ले लो. दिस इज ए सॉल्यूशन. इन दिस, फॉर एग्जांपल, आई हैव 1 gram of sodium chloride, 1 gram of sodium chloride and 1 liter of water. Okay, so amount of water, whatever is there, the amount of water is depicted by osmolality. Amount of salt is depicted by osmolarity. That's it. Osmolarity means amount of solute. Osmolality means amount of solvent. Bas. Okay, so decrease of ADH, decreased reabsorption of water, diluted urine, and increase of urine osmolality. Nephrogenic diabetes insipidus, here what happens is that there is the aquaporin 2 defect. Now what happens here is that very simple, aquaporin 2 defect, and it can be caused idiopathically and also can be due to lithium. Now simple si baat hai, see, normally ADH is produced from the central nervous system that will go and act in the kidney, where in the ADH receptor. If ADH receptors are not working, then we call it as a nephrogenic diabetes insipidus. If ADH itself is not produced, then we call it as a central. It is more like insulin dependent and insulin independent. Type 1 when type 1 insulin is not there, type 1 diabetes mellitus, insulin is not there. In type 2, receptors are not okay. Same way, in the central, ADH is not there. In nephrogenic, aquaporin 2 is not there. Bas baat simple. Okay, sir, if a patient comes to us, they will come with a common complaint. What is that? Polyuria and polydipsia. So how to differentiate between the central and nephrogenic? What I'm going to do is that I'm going to give a drug called as desmopressin. Desmopressin is a ADH analog. It is an analog of ADH. If I give desmopressin, if symptoms are improved, that is central, because ADH was not there. I gave ADH, treatment is done. ADH was not there. I gave ADH, treatment is done. So that is clearly telling you what. So ADH was not there. I gave ADH, symptoms improved. Then it is a central. So see, remember, for the central drug of choice is ADH is not there. You are giving ADH. Then why are you giving thiazide? For the central drug of choice is your desmopressin. The analog of ADH. For nephrogenic, the drug of choice, is thiazides. Okay. If lithium induced nephrogenic diabetes insipidus, drug of choice is amyloid. Okay, so the answer is, he gave desmopressin, still didn't improve, but still there is a symptoms of diabetes insipidus. The answer is nephrogenic diabetes insipidus. Let's go to the next question. A 56-year-old man is seen in the hospital for the chief complaint of intestinal thirst. Means he is having an increased thirst and polyuria. That's it. Okay, his history is significant for recent transsphenoidal resection of the pituitary adenoma. With regard to the man's fluid balance, which of the following would be expected? Very simple. You had a surgery. You had a surgery. So if there is a surgery, now listen to me. If there is a surgery for the pituitary adenoma, now he is having what is that? Polyuria and polydipsia. So there is an increased level of ADH. That is very clear. There is an increased level of ADH. If there is an increased level of ADH, think about this. It is not decreased level of ADH. There is an increased level of ADH. It is a case of SIADH. SIAD. If there is a more of ADH, it will increase the water reabsorption. Water reabsorption. Water reabsorption. Okay. If there is an increase of water reabsorption, remember directly, you just remember the point here. So in SIADH, the point you must remember is euvolemic. Euvolemic for exam is after, like, in 3 days. So for now, just remember, if they ask you about SIADH, you are supposed to point this only. Euvolemic hyponatremia. That's it. Directly remember. Euvolemic hyponatremia. Euvolemic hyponatremia. Euvolemic hyponatremia is a clear-cut indicator of what? A clear-cut indicator of increase of ADH level called as SIADH. So euvolemic hyponatremia. So simple point directly by headed. Euvolemic hyponatremia is a clear-cut finding present with what? Present with your, very good, present with your SIADH. So the answer will be your increased level of serum ADH. Okay, euvolemic hyponatremia. And the drug of choice for this patient is V2 antagonist. V2 antagonist. We have the drugs V2 antagonist. We have drugs such as Vaptans, Conivaptan, Tolvaptan. This MCQ was asked, what is the drug of choice for SIADH? So the drug of choice is Vaptans, Conivaptan and Tolvaptan. Okay, let's go to the next question. We are having last two questions. Okay, a 14-year-old female with no past medical history present to the emergency department with nausea and abdominal pain. On physical examination, her blood pressure is very low. Look here, her blood pressure is 78/65, respiratory rate is 30, her breath is having fruity odor, capillary refill time is more than 3 seconds, serum glucose is 820. After starting IV fluids, what is the next best step of management for this patient? Okay, first and most important, listen. She is having blood glucose level of 820, and she is having a fruity odor. She is just a 14-year. So this is a type 1 diabetes mellitus complicated into what is that? Complicated to diabetic ketoacidosis. So first line management for diabetic ketoacidosis is always IV fluids. Never mark the first option as what is that? Never mark the first answer as insulin. The first answer is always IV fluid, but here they started the IV fluids. What is the next best step of management? This is an emergency, boss. This is an emergency. So in emergency, don't tell that you are going to give a subcutaneous and wait. No, 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 no. The answer is IV regular insulin. First, few of you gave a correct answer. First, few of you gave IV regular insulin. IV regular insulin. This is a point to be remembered. IV regular insulin is given for the patient in an emergency case scenario of a diabetic ketoacidosis. And this question MCQ can also be asked to you people. Which insulin can be given? Which insulin can be given IV also? Among all the classification of insulin drug, only drug which can be given IV is insulin is regular insulin. Clear? Okay, let's go to the next question. A 20-year-old male brought by the ambulance to the emergency room in his extremes. Okay, he is minimally conscious, hypotensive and tachypneic, and his breath gives off a fruity odor. Arterial blood gas shows metabolic anion gap acidosis. This patient most likely defect in which of the following metabolic action? Okay, so here he is having a diabetic ketoacidosis. In diabetic ketoacidosis, he is having what is that? Excessive formation of ketone bodies. Okay, but more excessive formation of ketone bodies. But here they asked deficient in which of the following? हाँ यही तो ध्यान है, ये लगा दिए। डेफिशिएंट पूछा गया भाई। नाउ इन डायबिटिक कीटोएसिडोसिस तो देयर इज ए इंक्रीज ऑफ कीटोन, मुझे भी पता था, मैं भी इसलिए मैं तुम्हारे साथ चला थोड़ी देर के लिए, चलो कुछ कर देते बच्चों को, है ना। डायबिटिक कीटोएसिडोसिस में तो इंक्रीज ऑफ कीटोन, तो यहाँ पे पूछा गया डेफिशिएंट इन विच ऑफ द फॉलोइंग, है ना। तो deficiency is what? Deficiency is decrease insulin. If there is a decrease insulin, decrease glucose uptake, decrease glucose uptake, right? Right? So the answer is D. Cellular uptake of glucose is reduced. Okay? कोई नहीं, एक तो गूगलीबल में डाल सकता हूँ। अभी तक बहुत सारे मतलब ट्विस्ट एंड टर्न किया, बट ये गूगलीबल तो मैं भी करवा सकता हूँ। अब एक खुशखबरी, कुछ मतलब बहुत खुश होने वाली एक चीज बताता हूँ। क्या सर, इतने सारे आप जो पढ़ाए, इसमें से एक तो क्वेश्चन आएगा क्या? भाई सुन लो, इसमें से ना एक, ईच क्वेश्चन इज इक्वल टू 5 क्वेश्चन, ईच क्वेश्चन इज इक्वल टू 5 एमसीक्यू। इनमें से तो ऐसा हो ही नहीं सकता कि तुम्हें क्वेश्चन नहीं आए, समझ रहे हो? ऐसा हो ही नहीं सकता कि क्वेश्चन नहीं आए। सो इनमें से इन द सेम क्वेश्चन इट कैन बी कट इनटू 3-4 पार्ट्स। One question is equal to 5 MCQs here. That same question can be cut into multiple parts and asked. बट आप लोगों को क्वेश्चन जरूर आएगा, एक भी क्वेश्चन बाहर नहीं जाएगा। इनमें से तो मतलब बहुत सारे एंडोक्राइन क्वेश्चन कवर हो ही जाएगा, ठीक है। सो देयर विल बी देयर विल बी देयर। थैंक यू डॉक्टर साहब। सो ओ आप भी मतलब योर फेवरेट डॉक्टर डॉक्टर पारस इज हियर, तो उन्होंने अभी शायद लाइव कर रहे थे। एनीवेज यू मेड टाइम फॉर अस, थैंक यू। तो लिसन टू मी, लिसन टू मी। तो क्या बात है ना कि ये क्वेश्चन ना कट करके ये करके वो करके पूछेंगे, पूछने तो क्या क्या कर लेंगे, उतना कुछ डिफिकल्टी नहीं है, ठीक है। तो एक तो सिंपल बात है, ठीक है। अब दूसरी बात पे आते हैं, अब दूसरी बात पे आते हैं। दूसरी बात क्या है, तो आप लोग ने एक चीज छोड़ दिए थे, कौन सी? दैट इज योर मेटाबॉलिक एसिडोसिस अल्कलोसिस वाला पार्ट, है ना। तो इसको भी थोड़ा उठा के पढ़ ही लेते हैं, है ना। तो लेट्स टेक अप दिस, मतलब पूरा स्लाइड ही उठा दिया मैंने, मतलब ताकि तुम लोगों को ना वो वैल्यूज मुझे मतलब यहाँ पे डाल के समझाना ना मुझे बहुत आसान हो जाता है, इसलिए आई टुक दिस वैल्यूज टेबल, बस ये टेबल के लिए। थैंक यू। तो सुन लीजिए भाई, बहुत सिंपल सी बात है, पहले ना एक लिस्ट बनाओ, लिस्ट बनाओ पीएच, ओके। पीएच नॉर्मल पीएच इज 7.35 टू 7.45. Okay. Then look here, the next two important parameters you must remember is PCO2 and bicarb. PCO2 and bicarb. ठीक है, ऑक्सीजन को साइड में रखते हैं पर उसका इंपॉर्टेंस बहुत ज्यादा है, मैं समझाता हूँ, ठीक है। सो पार्शियल प्रेशर ऑफ कार्बन डाइऑक्साइड PCO2 इज फ्रॉम द 33 to 45 mm of Hg, mm of Hg. Then you have what is that? HCO3 minus, HCO3 minus, it is 22 to 28 milli equivalents per liter, okay. So these are the three parameters which I took, 1, 2 and 3, okay, sure. 22 to 28, okay. So these parameters are the parameters of your ABG, arterial blood gas analysis, आर्टेरियल ब्लड गैस एनालिसिस। तो ये आर्टेरियल ब्लड गैस एनालिसिस को देख के सर हम कैसा पहचान लेंगे ये मेटाबॉलिक एसिडोसिस है, ये क्या क्या ही चलता रहता है इसके साथ, ठीक है। अरे भाई बहुत फंडा सिंपल है, चलिए शुरू करते हैं एसिडोसिस। Very simple. See, this is a long theory. I'm going to make it into as short as possible. Acidosis. Acidosis can be due to respiratory or metabolic. So first, the important thing, acidosis means there is a decrease of pH. There is a decrease of pH. Okay. So it can be due to respiratory. It can be respiratory acidosis. So first, let's start with the respiratory acidosis. In the respiratory acidosis, what happens here is that, consider, my dear students, this is a lung. Okay. This is a lung. Okay. So you have your bronchus coming. So there is some foreign body into the bronchus. There is some foreign body in the bronchus. Now what happens is that जितने भी CO2 बनता है, CO2 cannot go out. Okay. So if there is a obstructive lung disorders or foreign bodies, obstructive lung disorders or foreign bodies, they close the airway. They obstruct the airway. Obstruct the airway. अगर एयरवे ऑब्स्ट्रक्ट हो जाता है तो ऑटोमेटिकली नेक्स्ट पॉइंट इज व्हाट, there will be, yes, there will be very very important point. So CO2 cannot go out, so CO2 retain in the body, CO2 retain in the body. अरे यार कुछ ज्यादा हो जाएगा बॉडी के अंदर तो कुछ ना कुछ होनी चाहिए, there should be something which should happen. Hello Dr. Sir. So there should be something which should happen. Carbon dioxide is not going out of the body, it will remain in the body. तो इसको करना क्या यार, मैं अधूरी हो गई, I would have gone out, okay, but he is not able to go out. अब इसको कुछ ना कुछ चाहिए होता है, सो इसका भी पार्टनर चाहिए, सो ही आल्सो नीड्स सम पार्टनर. ये भी ढूंढता रहते कोई यार पट जाओ मुझे. अब पटा लेगा किसको, पानी को. किसको पटाएगा, ओके. सो अरे समझाते यार, कॉम्पेंसेटरी अनकॉम्पेंसेटरी यूजुअली नहीं आते, बट यूजुअली आई विल हेल्प यू आउट, आई विल हेल्प यू आउट विद कॉम्पेंसेशन अनकॉम्पेंसेशन, सब सब कर लेंगे, टेंशन. तो दैट विल लीड टू व्हाट, H2CO3. H2CO3 क्या हो गया बॉस, इट इज ए acid, it is a carbonic acid. So retain of CO2 in the body, it will lead to acidosis, it will lead to acidosis. Okay, but which acidosis, retention of CO2 is respiratory acidosis. So in the respiratory acidosis, listen to me, there is a increase of partial pressure of carbon dioxide, yes, okay, and also decrease of pH कम हो जाएगा तो acidic. यहाँ तक तो आप समझिए. अब क्या होगा, listen to me, to compensate this, what can happen is that, so listen to me, if it is uncompensated में क्या होगा, so इसको मेंटेन करने के लिए, because of this acidosis maintenance, your body will respond to it by doing what. So listen to me, your HCO3 minus is there, it is base, HCO3 minus is base, ठीक है. So automatically if base is increased in the body, there is an increase of HCO3 minus, but still there is a acidic pH, then it is uncompensated. Okay, what do I mean by this, means पेशेंट को ना एसिडोसिस हो गया था, एसिडोसिस पेशेंट को रेस्पिरेटरी एसिडोसिस हुआ था, उसको कंपेंसेट करने के लिए HCO3 माइनस तो बढ़ा दिया, HCO3 माइनस बढ़ाया, HCO3 माइनस मींस बेस इफ यू इंक्रीज, सी दैट वाज एसिड, राइट. अब क्या था, एक था एसिड, देखो एसिड था, ठीक है. एसिड क्या हुआ था, ज्यादा हो गया, मतलब क्या हुआ था, एसिड ज्यादा हो गया, इंक्रीज ऑफ एसिड, ठीक है. उसको कंपेंसेट करने के लिए आपने क्या किया, बेस को बढ़ाया. बेस को बढ़ाने के बाद अब एसिडिक पीएच के अंदर बेस डालोगे तो पीएच क्या होना चाहिए, नॉर्मल हो जाना चाहिए. अगर नॉर्मल नहीं होता है, अनकंपेंसेटेड, ठीक है. बात सिंपल. अब कंपेंसेटेड अनकंपेंसेटेड का लॉजिक हर जगह इतना ही करो. अगर कंपेंसेट का मतलब क्या हो गया, इसके अंदर देखो PCO2 बढ़ा हुआ, एंड PCO2 बढ़ा है तो HCO3 माइनस भी बढ़ेगा, HCO3 माइनस भी बढ़ेगा. अब पीएच क्या हो जाएगा, नॉर्मल हो जाएगा. मतलब कंपेंसेट करने के बाद बाय रिटेनिंग द बाइकार्बोनेट वी आर गेटिंग आवर पीएच टू ए नॉर्मल लेवल. पीएच नॉर्मल हुआ किसके वजह से, HCO3 माइनस बढ़ने के वजह से, उसको बोलते हैं कंपेंसेटेड. मतलब कहीं पे भी जब हिस्ट्री देखनी चाहिए. First, a patient came to the hospital with a severe attack of bronchial asthma. Severe attack of bronchial asthma मतलब respiratory airways are closed. So automatically it is a respiratory acidosis. Based on that respiratory acidosis diagnose बना के फिर apply करो compensation and uncompensation. ठीक है भाई, ठीक है. compensation uncompensation समझ में आएगा, ठीक है. बट इतना आपको चाहिए कि यूजुअली नहीं है ये compensated uncompensated नहीं आते, यूजुअली ये वाले. So increase of PCO2, increase of pH, and anywhere if there is a obstruction, respiratory acidosis. चलिए आगे बढ़ते हैं. मेटाबॉलिक एसिडोसिस. सो एक सेकेंड है, मैं कैन यू टेल दिस क्वेश्चन अकॉर्डिंग टू माय एक्सपीरियंस. सी पार्शियल एंड अनकंपेंसेटेड आर प्रीटी मच सेम थिंग. ओके, मेरे एक्सपीरियंस के हिसाब से तो तुम लोग जो अटेम्प्ट लिख रहे हो, यूजुअली जो अटेम्प्ट तुम लोग लिख रहे हो, इट इज सपोज टू बी इन द दिसंबर अटेम्प्ट जो हो रहा है वही हो रहा है जनवरी में. ठीक है, यूजुअली दिस पेपर्स आर सिंपल. ऐसा भी नहीं बोलूंगा कि मतलब झूठ नहीं बोलूंगा कि भाई तुम लोग मतलब बहुत आसान आ जाएगा, इतना झूठ नहीं बोलूंगा. बट यूजुअली जितना मैंने देखा हुआ है, दिसंबर पेपर्स आर सिंपल कंपेयर टू दैट ऑफ जून पेपर. तो दिसंबर पेपर जो जनवरी में लिख रहे हो जो आसान होगा, आसान मतलब ऐसा भी नहीं है कि हाँ सारे पूछेंगे कि ह्यूमन बॉडी के अंदर कितने बोन है, ऐसे इतना भी नहीं है, बट डिसेंट है ना, नॉट सो वेरी वेरी डिफिकल्ट। मतलब पहले तुम लोग एक्सपेक्ट करते हो ना कि यार बहुत डिफिकल्ट आ गया, ऐसा कुछ नहीं होगा, बट मॉडरेट आएगा। ये हमारे गेस्ट है, लेट्स सी। ठीक है, अब एनबी वाले कभी निराशा नहीं करते, हम लोग पूरा प्रिपेयर होके गए थे। हाँ, ये बहुत नॉर्मल है भाई, ये फील होनी भी चाहिए, दैट मीन तुम लोग पढ़े हो। ठीक है, तुम अचानक से तुम याद करने का कोशिश करोगे, मतलब ऐसा बैठूंगा मैं, हाँ आजा नोट्स, मेरा मेडिसिन नोट्स आजा, नहीं आने वाला। वो एक्सपेक्टेशन भी मत रखना, इसमें कोई गलत नहीं है नहीं आने से। ठीक है, मैं मजाक नहीं उठा रहा हूँ आपका, मैं बोल रहा हूँ कि तुम आंख बंद करके अचानक से हर चीज रिवाइज करने से नहीं होता है। ऐसा नहीं होता है कि तुम उस दिन जाओगे एग्जाम हॉल के अंदर बैठोगे, क्वेश्चन पढ़ोगे, थोड़ा दिमाग लगाओ, हाँ इस पेज में पढ़ा था, ये चैप्टर में ये क्वेश्चन के बारे में पढ़ा, तब जाके तुम सॉल्व कर सकते। अब इतना 2 दिन के अंदर तो तुम कुछ चेंज नहीं कर पाओगे, है ना। तो जो तैयारी कर रहे हो पूरा पूरा 100% अपना लगा के रहो। ठीक है, पूरा लगे रहो, इसमें कोई ये नहीं है। एंड एट ए गिवन पॉइंट ऑफ टाइम, यार आज तक मैं इतना पढ़ाता हूँ ना, मुझे खुद को फार्मा मेडिसिन याद नहीं आता ऐसा आंख बंद करने से। ठीक है, इसमें तुम्हारा गलती कुछ नहीं है, इट्स टोटली फाइन माय डियर। ठीक है, इसको लेके डरना मत, इसको लेके डरते हुए कोई दूसरा सब्जेक्ट मत छोड़ना, आपका तैयारी जो है वो करते रहिएगा, बस आप करते रहो करते रहो करते रहो। ठीक, अब कितना है, 3 4। ठीक, जाओ एग्जाम में आराम से आते हैं, ऐसा भी नहीं है कि ऐसा कुछ नहीं। ठीक है, तो और दूसरी बात यार, इंसान का दिमाग साला पढ़ने के लिए बना ही नहीं है। मैं बोल देता हूँ, मैं खुलेआम बोल देता हूँ, यू ह्यूमन ब्रेन इज नेवर मेंट फॉर स्टडीज। ह्यूमन ब्रेन इज मेंट फॉर ईट, स्लीप, रिप्रोड्यूस। ठीक है, तो अब इतना इस चीज को एट दिस पॉइंट ऑफ टाइम, नाउ यू हैव ट्रेन्ड योर ब्रेन सो मच एट दिस पॉइंट ऑफ टाइम, ओके हैव कॉन्फिडेंस ऑन योर ब्रेन एंड योरसेल्फ, थोड़ा काम हो जाओ, क्योंकि देयर इज नो अदर ऑप्शन देन कीपिंग योरसेल्फ काम। ठीक है, दैट इज माय पॉइंट ऑफ व्यू, तुम्हारे पास कोई ऑप्शन भी नहीं है। ठीक है, मतलब लड़की काट के चली गई तो चली गई, मतलब तुम्हारा कट गया तो कट गया, फॉर एग्जांपल मैं यहाँ पे किसी को ऑफेंड नहीं कर रहा, कट गया तो कट गया, कोई ऑप्शन नहीं है तुम्हारे पास, मतलब अब होल्ड ऑन करना ही पड़ेगा, वैसे ही तुम्हारे पास एग्जाम हो। ओके, चलो मेटाबॉलिक एसिडोसिस, यार मेटाबॉलिक एसिडोसिस में पीएच क्या होगा, डिक्रीज ऑफ पीएच, यस सर। यहाँ पे यहाँ पे नॉर्मल लेवल ऑफ CpCO2, क्योंकि PCO2 हैज नथिंग टू डू विद द मेटाबॉलिक प्रोसेस, तो क्या होगा, देयर इज अ डिक्रीज ऑफ HCO3 माइनस, HCO3 माइनस। सो HCO3 माइनस क्या दिखाता है आपको, मेटाबॉलिक पैटर्न को दिखाता है, मेटाबॉलिक पैटर्न को दिखाता है। PCO2 क्या दिखाता है, PCO2 PCOS नहीं है, पार्शियल प्रेशर ऑफ कार्बन डाइऑक्साइड क्या दिखाता है, रेस्पिरेटरी। मेटाबॉलिक एसिडोसिस कैन बी कॉज्ड बाय डायबिटिक कीटोएसिडोसिस, लैक्टिक एसिडोसिस, lactic acidosis, okay, lactic acidosis, okay. Then any other places where metabolic acidosis can happen? Any other places? यार एक ड्रग इतना अच्छे से पढ़ते हो, दैट इज योर कार्बोनिक एनहाइड्रेस इनहिबिटर ड्रग्स, कार्बोनिक एनहाइड्रेस इनहिबिटर ड्रग्स, ओके। तो सिंस दे कॉज मेटाबॉलिक एसिडोसिस, दे कॉज मेटाबॉलिक एसिडोसिस। ठीक है, तो मेटाबॉलिक एसिडोसिस का एग्जांपल, चलिए रेसिपी के मतलब अल्कलोसिस में बढ़ते हैं। अल्कलोजिस, अल्कलोसिस, एसिटाजोलामाइन, ओके। अल्कलोसिस का क्या कहानी है यार, दो तरीके का अल्कलोसिस हो सकता है, एक होता है रेस्पिरेटरी, एक होता है मेटाबॉलिक। सर रेस्पिरेटरी अल्कलोसिस क्या सीन है यार, उस टाइम पे क्या हो रहा था, व्हाट डिड आई टेल यू, इन द रेस्पिरेटरी एसिडोसिस देयर इज अ ब्लॉकेड, देयर वाज अ इंक्रीज ऑफ CO2, है ना। तो हियर व्हाट विल हैपन इन द अल्कलोसिस, अल्कलोसिस के अंदर बहुत सिंपल कहानी है, कोई ऑब्स्ट्रक्शन ऑब्स्ट्रक्शन कुछ नहीं है, व्हाट विल हैपन इज दैट देयर इज अ इंक्रीज ऑफ रेस्पिरेटरी रेट, वहां पे रिटेंशन हो रहा था, यहाँ पे क्या होता है देखो, इंक्रीज ऑफ रेस्पिरेटरी रेट, देयर इज अ लॉस ऑफ कार्बन डाइऑक्साइड, इट विल लीड टू हाइपोकैप्निया, हाइपोकैप्निया, okay, loss of excessive loss of CO2, increase respiratory rate, increase loss of CO2, increase loss of CO2, automatically it will lead to alkalosis, it will lead to alkalosis. The funda is very clear, what is that, respiratory alkalosis will be caused as a due to a result of loss of carbon dioxide, loss of carbon dioxide. Respiratory acidosis is due to what, exactly, respiratory acidosis is due to retention of carbon dioxide. Okay, so this will occur at what? Occur at high altitude. Last exam ka question, high altitude, high altitude. So it will lead to what? It will lead to mountain sickness. Mountain sickness. तो mountain sickness में क्या होता है? High altitude में जाओगे, लेह लद्दाख में चले गए, ट्रिप में गए थे, what will happen? Because you are at a height, तो ज्यादा breathe करोगे, ज्यादा loss of carbon dioxide, excessive carbon dioxide loss will lead to alkalosis, lead to mountain sickness. Okay, mountain sickness. If there is a mountain sickness, what will happen? What will happen? So you are having one more thing. Very good answer here. एक main चीज भूल गए हम लोगों ने, ये respiratory alkalosis acidosis में. Why you are doing? Why? Because of one thing. Because in the high altitude there is a lack of partial pressure of oxygen. So partial pressure of oxygen will be reduced. So automatically what will happen? In the body, SpO2 will be reduced. SpO2 will be reduced. So in a high altitude, in a mountain sickness, we will have a respiratory alkalosis. The drug of choice is your carbonic anhydrase inhibitor, acetazolamide. Acetazolamide. Okay, acetazolamide. Now here only I will clear it once again. For mountain sickness, drug of choice is acetazolamide. For morning sickness, drug of choice is a doxylamine with vitamin B6. Okay. Okay. So then the last one will be, what is that? Metabolic alkalosis. Metabolic alkalosis. Metabolic alkalosis का क्या कहानी है सर? अरे metabolic alkalosis और भी easy है यार. Metabolic alkalosis means what? Loss of what is that? Hydrogen ion should occur. Point number one. Or hydrogen is acid. Acid goes out of the body. Body will become alkalosis. Okay. Then or there is a retention of HCO3 minus. ये दोनों में कुछ भी हो जाएगी. If you increase the HCO3 minus or loss of hydrogen ion, that will lead to metabolic alkalosis. Absolutely correct answer. Metabolic alkalosis can be seen with vomiting. Vomiting में क्या होता है? Vomiting में from the stomach all the acid will be lost. If all the acid will be lost, your body will become alkaline. So in the vomiting is classically associated with the congenital hypertrophic pyloric stenosis, that is your CHPS. CHPS. So again, GU stands for, तुम लोग जो सोच रहे हो वो नहीं है, gastric outlet obstruction. Gastric outlet obstruction. And the last one is a Conn syndrome. Conn syndrome में क्या होता है? Conn syndrome, what happens? There is an increased level of aldosterone that will cause, ab sabko pata tha, it will cause a loss of potassium ion. Along with that, it will also cause the loss of hydrogen ion. Remember this, Conn syndrome may also cause a loss of hydrogen ion, leading to metabolic alkalosis. Sir, metabolic alkalosis हमें कैसा पता चलेगा? अरे ऐसा पता चलेगा कि alkalosis से तो increase pH. Okay, and also normal level of, Anji sir, normal level of PCO2 and alkalosis matlab increase of HCO3 minus loss of HCO, increase of HCO3 minus, and loss of potassium. Instead of potassium, sometimes there can be loss of hydrogen also. That is a aggravating factor for metabolic alkalosis. Potassium loss is there, along with that hydrogen will be lost. Okay, so let's look at one simple question. I had a patient was brought to the hospital. Is ABG revealed like this? Let's see how many of you can answer. Okay, pH 7.2, PCO2 that is 60, and HCO3 minus that is HCO3 minus, that is 26 milliequivalents per liter. What is the diagnosis? What is the diagnosis? Okay, come on, everybody tell me, what is the diagnosis? Very good. The diagnosis is respiratory acidosis. कैसा पता चला respiratory acidosis? pH is acidic. Okay, PCO2 is increased and milliequivalents per normal. यार इतना ही लगाओ जितना मैंने समझाया एबीजी के अंदर. पहले pH देखो, acidosis alkalosis डिसाइड करो, then look at partial pressure of carbon dioxide, then look at HCO3 minus, तुम्हारा आंसर आ ही जाएगा. अगर वैसा नहीं है, दूसरा तरीका, if there is a hyperventilation, then respiratory alkalosis. Hypoventilation or obstruction, respiratory acidosis. If diabetic ketoacidosis is there, metabolic acidosis. Loss of hydrogen like Conn syndrome is there, metabolic alkalosis. वैसे भी कर सकते हो, ऐसे भी कर सकते हो, ठीक है. Let's go to the next question. Let's see if you can answer. So pH of 7.49, pH of 7.49, PCO2, PCO2 of your 35 and HCO3 minus, HCO3 minus is of 29 milli equivalent per liter. Patient is also having with the complaints of what is happening? Complaints of fruity odor, fruity odor, fruity odor, and also patient is having loss of consciousness. Loss of consciousness. What is your diagnosis? Okay, leave about this loss of consciousness को हटा ही देते हैं, fruity odor को हटा ही देते हैं. Okay, what is the diagnosis? Okay, very good. The answer is metabolic alkalosis. Metabolic alkalosis. Okay. Now patient is having loss of consciousness, fruity odor, fruity odor. Okay. Then what is the diagnosis? Diabetic ketoacidosis. Okay, so this is the story of your what is that respiratory acidosis and alkalosis. Last 5-10 minutes में मैंने जितना पढ़ाया आप लोगों को respiratory alkalosis acidosis के बारे में, एक बार जस्ट रिवाइज करने का टाइम पे चाहिए तो आप वीडियो कोई 2x स्पीड में, मतलब एट द एंड ऑफ आवर रिवीजन वीडियो कोई 2x का स्पीड में लगा के देख लो, बस तुम्हारा रेस्पिरेटरी एसिडोसिस अल्कलोसिस कोई गलत नहीं करना सकता. ठीक है, चलिए इतना बोलने के बाद मुझे पता है आफ्टर एंडोक्राइनोलॉजी तुम्हारा दिमाग के तुम्हारा ब्रेन ऐसा लग रहा है कि कोई 2 किलो एक्स्ट्रा वजन बढ़ गया, तो लो भाई ब्रेक लो एक. ठीक है, वंस यू टेक ए ब्रेक एंड कम बैक देन वी विल कंटिन्यू विद द कार्डियोवास्कुलर एंड इसमें पढ़ाऊंगा मैं ईसीजी एंड मर्मर्स. दिस विल बी द मेजर चंक ऑफ योर मेडिसिन का रिवीजन. ओके, सो टेक ए ब्रेक टिल 8:30. अब मुझे ये मत बोलो कि सर डिनर का ब्रेक दे दो, कोई दिक्कत नहीं, एक दिन डिनर लेट करने से. ठीक है, अभी 2 दिन के अंदर क्या करना है? पहली चीज डरना नहीं है. अब इतने दिन जो भी कर रहे थे वट एवर यू हैड प्लान, ओके लास्ट 2 डेज में ये पढ़ूंगा, लास्ट 2 डेज में ये पढ़ूंगा, वैसे ही पढ़ो. रोज रोज अभी 2 दिन है, 2 दिन के अंदर एक बार हो पाएगा तो 1-1 घंटा या 2-2 घंटे एक बार प्रीवियस ईयर क्वेश्चंस देख लो. ठीक है, एंड द लास्ट डे के सब्जेक्ट्स पीएसएम रिवाइज करो. लास्ट डे में पीएसएम मतलब पूरा पीएसएम वर्ड टू वर्ड नहीं, क्विकली ऐसा. देन लास्ट डे में तुम रिवाइज करोगे तुम्हारा ओबीजी एंड सर्जरी, पीएसएम ओबीजी सर्जरी. और इसके बाद अगर तुम्हें टाइम बचता है तब करो व्हाट इज दैट इज व्हाट एवर सब्जेक्ट इज डिफिकल्ट. ओके, एंड वन डे बिफोर दैट यू डू द अदर सब्जेक्ट, बट मोस्ट इंपॉर्टेंट सब्जेक्ट कीप इट फॉर द लास्ट डे ऑफ रिवीजन. पॉइंट नंबर 1. एंड ऑन द डे ऑफ एग्जाम दिन सुबह उठोगे ना, उठने के बाद एग्जाम मतलब तुम एग्जाम हॉल निकलने से पहले एग्जाम हॉल जाने तक बायोकेम रिवाइज कर लो और पैथ का हेमेटोलॉजी रिवाइज कर लो. ठीक है जी, चलिए टेक ए ब्रेक टिल 8:30 एंड विल कम बैक. Hello everyone. All right. तो हो गया अपना break. We are done with the break. Let me open the live so that I'll be able to look at your comments. है ना? तो let's start with the discussion. So what exactly we started with? We started with our, what was that? That was your rheumatology, then we went to endocrine, then we went to respiratory acidosis, alkalosis, etc. Right? Once we are done with all of them, now let's study about the next part. What is the next part, my dear student? The next part is very interesting. That is going to be your what is that? Okay, audio video is clear. The next part is your most weighted cardiology, right? So cardiology के अंदर कार्डियोलॉजी के अंदर आप लोगों का पूरा रिवीजन, मतलब आई एम नॉट गोइंग टू डू वन डिसीज बाय वन डिसीज, बट आई विल टीच यू टेक्निक्स हाउ टू हैंडल कार्डियोलॉजी. ठीक है. द मेजर डाउट एंड मेजर फियर फॉर यू पीपल इज हमेशा ईसीजी. अरे भाई ईसीजी कैसा करें, मतलब क्वेश्चन सॉल्व करेंगे, क्यों टेंशन लेना है ना. तो अब बनी रहिए. तो इफ ईसीजी क्वेश्चन कम्स, from the images we are going to discuss, from the images which we are going to discuss, from those only where ECG question will be there for sure. Okay, so please focus on the ECGs which I am going to teach you people. The ECG is very easy. तो फर्स्ट एंड मोस्ट इंपॉर्टेंट हम लोगों को क्या चाहिए, एक बेसिक चाहिए होता है. ओके, ईसीजी में क्या चाहिए, एक बेसिक चाहिए होता है. वो बेसिक के बाद आप कुछ भी कर सकते हो. ओके, यू कैन डू एनीथिंग विद ईसीजी. ओके, तो चलिए एक के बाद एक सीखते हैं. ठीक है. सो इन द ईसीजी फर्स्ट एंड मोस्ट इंपॉर्टेंट थिंग इज दैट आपको कैसा क्वेश्चन आएगा, कैसा टैकल करना है, वो सिखाऊंगा पहले. ठीक है. आपको एक इमेज बेस्ड क्वेश्चन देंगे. वन ईसीजी क्वेश्चन विल बी गिवन टू यू. Okay. Now one ECG will be given to you. The point of view is to do what? Two types of questions are asked very frequently. Commonest forms are two questions. One is, what is the diagnosis of the ECG they have given you? Point number one. The other possibility they can ask you a question is that for this given ECG under disease, what is the treatment? ठीक है. यही दो तरीके का क्वेश्चन आता है. तो ट्रीटमेंट क्या करोगे, एक क्वेश्चन, या नहीं तो डायग्नोसिस क्या है, दूसरा क्वेश्चन. तो इसको कैसा हैंडल करें, बढ़िया सिंपल सा. सो फर्स्ट एंड मोस्ट इंपॉर्टेंट, इफ यू टेक एनी ईसीजी यू हैव वेव्स. ये बहुत अच्छे से सीखना चाहिए, देन यू विल अंडरस्टैंड रेस्ट ऑफ इट. तो यू हैव द फर्स्ट पॉजिटिव वेव. हमेशा लाइफ टाइम के लिए याद रखो, इन द ईसीजी फर्स्ट पॉजिटिव वेव इज कॉल्ड एज पी वेव. We call it as a P wave. First positive wave is called as P wave. So the first positive wave is called as P wave. This occurs because of atrial depolarization. It occurs because of atrial depolarization. So जब भी दोनों atrial depolarize होते हैं, ये P wave बन जाता है. Whenever atria is depolarized, P wave is formed. Agar if there is a defect in the P wave, that means the defect is located in the atria itself. P wave is, if there is a defect in the P wave, then there is a defect in the atria. ठीक है भाई. चलो, then यहाँ पे ये देखो, which I am highlighting with the blue color here. Okay, so this one will be an interval, and इसके बाद आता है एक negative wave आता है, that is only called as Q wave. That is only called as Q wave. The Q wave के बाद जो भी positive wave आएगा R wave, उसके बाद जो भी negative आएगा that will be S wave. So any negative wave after the R wave is S wave, and the last positive wave is T wave. Okay, so if multiple waves are involved together, we call it as a complex. So we have QRS complex. We have QRS complex. So QRS complex will arise as a result of what? QRS complex will arise as a result of ventricular depolarization. Ventricular depolarization. Okay. Then the last one is there, T wave. The T wave will come as a result of what? As a result of your one simple thing. What is that? Is it because of ventricular repolarization. Pay attention, ventricular repolarization. ये कोई और नहीं है, ventricular repolarization. From physiology, these itself are a direct MCQs. P wave क्या है, QRS क्या है, T wave क्या है. Okay, now if I'm highlighting with a blue color which I have highlighted, right? So there is a interval, there is a between two waves, P and Q wave. We call it as a PQ interval. A PQ interval, what does it signify? PQ interval tell me that now in the heart you have two atrias, two ventricles, right? So in the SA, in the atria you have a SA node, here you have a AB node. Right? So from the SA node, signal will go to the atrias, as well as it will go to the AB node. Signal will go to the SA atria as well as to the AB node. In the AV node, signal will remain for some time called as delay will occur, delay of the signal. Since there is a delay of the signal, what you are getting in the ECG, see, there is no electrical activity. If there is no electrical activity, that means neither positive nor negative. Okay, so what exactly I'm trying to tell you? Thank you. So what I'm trying to tell you is very simple funda. Simple thing is that, so signal is struck, so no electrical activity, flat line, PQ interval, that is signifies your very interesting thing. What does it signify? PQ interval signify AV nodal delay, AV nodal delay, AV nodal delay. Now interestingly understand with me, if AV nodal delay, if it is prolonged, if it is delay is for too long, right? If delay is for too long, means there is a blockage occurring in the AV node. If for example, I will put one extra pathway to ventricle, I will put extra route. If I put an extra route, now signal will directly go to ventricle. There will be AV nodal delay will be not there. AV nodal delay will be not there. So this is also a important point to be remembered. सारे समझाऊंगा मैं step by step. Now, so if you are looking at any of these things, what exactly is this first ECG? Let's look at the first ECG. जब भी आपको 12 lead ECG दिया जाता है, if they give you a picture of 12 lead ECG and you are making a diagnosis, this is related to rhythm, means you must always look at the rhythm strip, that is always lead 2. Lead 2, we will have one lead 2 printed over here, but the long lead 2 will be printed in the bottom of the ECG usually. Okay, so in the bottom of the ECG, if you look here, now please understand P Q R S T, then next P Q R S T. Now one R wave to another R wave, we call it as a RR interval. RR interval means the time taken for one beat. Time taken for one beat. Agar if there is a decrease of RR interval, means one beat to another beat time is less. समझो, एक बीट से दूसरा बीट के बीच में टाइम कम है, मतलब एक मिनट के अंदर नंबर ऑफ हार्ट बीट्स आर मोर. समझ में आ गया सबको? सो इफ देयर इज अ डिक्रीज ऑफ आरआर इंटरवल, दैट मींस इंक्रीज ऑफ हार्ट रेट. इफ देयर इज अ इंक्रीज ऑफ आरआर इंटरवल, मींस फ्रॉम वन बीट टू अनदर बीट इट इज टेकिंग टू लॉन्ग. एक बीट हुआ लब, ओके, लब लब, एक हार्ट बीट हुआ, नाउ इट विल टेक 1 सेकंड पॉज, लब. That means the RR interval become more far. That means decrease of heart rate. समझ में आ गया? Okay, so decrease of RR interval, decrease of RR interval, that is your, what is that? Decrease of RR interval is what? Decrease of RR interval is tachycardia. Increase of RR interval is your bradycardia. Okay, so once you understood about your tachycardia and bradycardia, now listen to me. Here in this ECG, let's zoom in and understand in the rhythm strip. Okay, now first and most important thing, what I notice here, what you are noticing, what I am noticing here is that this is one R wave, this is another R wave, this is another R wave, this is another, this is one. Okay, from one R wave to another R wave, is there any constant interval or the interval is keep on changing? ध्यान से देखो, one R wave to another R wave, the interval is keep on changing. So यहाँ पे देखो RR interval, the interval has suddenly increased. Okay, so point number one is different RR interval. And if you notice very keenly here, can you notice any P wave? Clear cut P wave is absent here. Clear cut P wave is absent. So the criteria for your ECG, what you are looking at, I will tell you. So constant change of RR interval, constant change of RR interval, okay, and no P wave. This is a clear cut indicator that atrial fibrillation में होता क्या है, ध्यान से सुनो. दो एट्रिया ऐसा, ठीक है, ये दोनों एट्रिया, both the atria must contract together. Now instead of atria contracting together, the atria is doing a dance like this. जब atria पूरा contract करता था, P wave आता था. When atria contracted fully and depolarized fully, P wave was coming. Now atria is doing this dance. So will you have a P wave? No, there is no P wave. Whatever you are looking at, we name these P waves as F waves. We name this as F waves. But F wave, even if you forget, no problem. Atrial fibrillation, change of RR interval, no P wave is a clear-cut sign of atrial fibrillation. So if the patient comes to you with the atrial fibrillation, now listen to me, the drug of choice is beta blockers. Beta blockers is equally effective to that of calcium channel blockers. Calcium channel blockers such as diltiazem, okay, or verapamil, verapamil. Okay. Now, atrial fibrillation most commonly occurs due to a problem, due to a problem, that is dilation of atria, dilation of atria. So there is a dilation of atria. Because of dilation of atria, because of dilation of atria, atrial fibrillation will occur. Beta blocker and calcium channel blockers are equally effective. अगर मैं क्वेश्चन दूंगा asthma patient, a patient is having asthma and also having atrial fibrillation, then what will be the drug of choice? Then आप लोग जाओगे कहाँ पे? CCB, because calcium channel blockers are better option than beta blocker in a patient with asthma. But as such, if you are looking simple rule, different RR interval with no P wave, atrial fibrillation, dilation of atria will occur. So this dilation of atria will lead to some problem called as ectopic beat. Ectopic beat. Usually in the atrial fibrillation, ectopic beat comes from pulmonary veins. So from the pulmonary veins, ectopic beat will come. But the drugs are beta blocker and calcium channel blockers are used. Okay, that's the story of your atrial fibrillation. Now let's go to the next one. Now remember one atrial contraction. So rule is very simple. One P wave is there. That means the next one QRS should be there. QRS should be there, one T wave should be there. This is a normal rule. But if more number of, if you notice here, this is also one P wave, 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 here also P wave, here also P wave. Here you have more number of P wave, increase number of P waves, increase number of P waves. But यहाँ पे क्या होता है, P waves are there, and if you notice here, RR interval is almost constant. With a constant RR interval, then what is the diagnosis? Listen to me very carefully. The diagnosis is atrial flutter. What do I mean by this? So please listen to me. Both the atrias are sitting like this. Dum, dum, dum. Atrias are contracting 3 times or 2 times, then one ventricular contraction is coming. So here if you notice, my dear student, here if you notice, how many P waves are there? 2 P waves. And how many are there? One QRS is there. So one QRS is there. Then we call it as a 2:1 block. 2:1 block. This is a diagnosis of 2:1 block. Like this only you can get 2:3 block also, and 4:1 block also, 5:1 block also possible. But most commonly you are going to get in the exam is 2:1 or 3:1 block. So more number of P waves than the QRS complexes. If you notice here, the P waves are looking as if like a sawtooth appearance. P waves are looking like a sawtooth appearance. This is a case of atrial flutter. Atrial flutter usually is a benign condition, means it might not even require the treatment. So that is a story of your, what is that? Story of your atrial flutter. This is a case of, what is the disease? Atrial flutter. Okay. So this is a story of your, what is that? Story of your atrial flutter. So once you understood about this, just one second, let me adjust this one. Okay. So neuromedicine and see immune system, I have covered it, most of it from your, what is that? From your this one, what is that? From your pathology itself. And if at all neuromedicine, see neuromedicine, we don't have that much time right now. But neuromedicine, I'll tell you the important topics what you must go through at the end. Okay, because still we have a lot of cardio to complete. Let's go to the next scenario. See, this is a 12 lead ECG, but in all of the 12 leads, we have same diagnosis. What is the diagnosis? My dear students, please understand, normally you have P, QRS and T. Okay. For example, if I put like this, now can you tell me what is happening? The importance is that there is an increase of PQ interval. So if you look at a PQ interval increase, then what do you call it as? So if there is an increase of PQ interval, that is seen with the AV block. Why AV block? Because the signal comes to the AV node. Signal comes to the AV node and signal remains in the AV node. Signal remains in the AV node. That time the duration will be prolonged. Okay. So if there is a prolongation of their AV block, AV block can be divided into 3 degrees. There is first degree AV block, first degree AV block. Okay, so in this first degree AV block, if you notice here, so there is no significant change in every lead. If you notice in the second lead, if you notice, the PQ interval is prolonged. PQ interval is prolonged than the normal. So just in the AV block, first degree AV block, only change will be increase of PQ interval. That is the only change you can find in a ECG of first degree AV block. ECG of first degree AV block. Okay, now let's go to the next one, that is second degree AV block. Second degree AV block. In the second degree AV block, if you notice here, my dear students, PQ interval, there is an increase. Then if you go to the next ECG, PQ interval is more than the first one. Okay, then if you go to the third ECG, PQ interval is more. Okay, PQ interval is more. And if you go to the fourth ECG, PQ interval is even more. But if you go to the fifth one, there is only P wave, there is no QRS formation. Means QRS is not there, means beat is getting skipped itself. So that is a part of your second degree AV block. So in the second degree AV block, we have two types. That is called as Morbitz type 1, Morbitz type 1, Morbitz type 1. Okay, we have first one is called as Morbitz type 1. We have one type called as Morbitz type 1. Okay, Morbitz type 1, what will happen is that continuously क्या हुए जा रहा है? Continuous, very good, continuous increase of PQ interval followed by beat skipping. Followed by what? Beat skipping. Followed by what? Beat skipping. Followed by the beat skipping. If there is a continuous PQ increase and followed by that if beat skipping is there, then we call it as a Morbitz type 1. So PQ prolonged, next is even next beat more prolonged, third beat even more, fourth beat even more, and the next beat there will be skipping of the QRS complexes. Clear everybody? That is called as Morbitz type 1. Okay, now once you understood about the Morbitz type 1, let's go to the next one. What is the next one we need to understand? The next one which we need to understand is Morbitz type 2, my dear. What is that? Morbitz type 2. So we have Morbitz type 2. Okay, Morbitz type 2 में क्या होता है? Morbitz type 2 में most important point here is that there is a constant PQ interval. Constant PQ interval means PQ interval might be increased or it can be normal. PQ interval will be constant or normal. But if you notice normal ECG heartbeat, but if you notice here you find only one P wave, but there is no QRS complex. Constant PQ with the beat skipping. We call it as what? Constant PQ interval with a beat skipping. We call it as a Morbitz type 2. Called as a Morbitz type 2. Okay. Then let's go to the third degree AV block. So let's go to the third degree AV block. Here you have a third degree AV block. What is this third degree AV block? So third degree AV block, my dear students, it's very easy for you to understand. What is this third degree AV block? तो यहाँ पे SA node and AV node के बीच में कोई relationship ही नहीं रहेगा. Normally third degree AV block में क्या होता है? Listen to me. Normally SA node generates how many beats per minute? 60 to 100 beats per minute. 60 to 100 beats per minute. So once SA node generates 60 to 100 beats per minute, you will have 60 to 100 P waves will be there. 60 to 100 P waves will be there. But the problem here is that if you look at this, if this is your atria, this is your ventricles, and if you look here, this is your SA node and this is your AV node. Okay. Now what happens is that signal from the SA node will come to AV node, but from AV node this signal will not go. Means signal will not go from the AV node to below. Means SA nodal signal, whatever signal generated by SA node, that will not go to ventricles. If that will not go to ventricles, then what is happening? Now AV node will become into action. Now see, AV node was not allowing the signal to go down. AV node on its own, it will send up to 40 waves. 40 QRS complexes would be there. Why? Because very simple, AV node is blocked completely, means signal from the SA cannot go to AV, cannot go to ventricle. Now, if the AV node is blocked completely, means it is not conducting, but it is having its own property to generate the signal that is there. So it will generate up to 40 beats per minute. Okay. So simple funda, what is that? In the complete AV block, what will happen? There will be very few QRS complexes, but more number of P waves. That too, there is no bit. So if you notice here, so there is one QRST, PQRST, then again one P wave, one P wave, one P wave, one P wave, and again you got one QRS, one more QRS, then again you got P wave. So if you look here, there is no relationship between P wave and QRST, P wave and QRST. So no relation between what is that P wave and QRS complexes. Means SA node is doing its own work separately forming P wave, AV node is doing its own work forming QRS complexes. Both of them are not in a sync, called as a type 3 or third degree AV block. That is only called as third degree AV block. Now there are some few MCQs, favorite MCQs. The treatment for AV block, best drug is atropine. Best drug is atropine. And best treatment is always, my dear student, artificial pacemaker. What you are going to do? Artificial pacemaker you are going to give it as a treatment. Okay, so this is the treatment of your third degree AV block. Not even third degree, if needed even in the second degree also, you are going to do only one treatment. Artificial pacemaker is the best treatment. But if you are in a village setup, or if you diagnose it in a place where you cannot do an artificial pacemaker, then what you are going to do is that you are going to give him atropine and send the patient to the next place, next higher center. Okay, then let's go to the next image. What is this next image? Okay, this next image is very interesting. We have something called as bundle branch blocks. So bundle branch block समझने से पहले एक देखो, यहाँ पे तुम्हारा atrius है. So you have your ventricles. Between here you have bundle of fish. From here left to right bundle branch and a left bundle branch. All of you know. If there is a block in the left bundle branch, क्या होता है? If there is a block in the right bundle branch, what will happen? We are going to know. तो यहाँ पे अब हमारे पास इतना टाइम नहीं है कि वोल्टेज कैसा स्प्रेड होता है, ये कैसा स्प्रेड होता है, वो सब देखने के लिए हमारे पास क्या है, हमारे पास बहुत कम टाइम है. वी नीड टेक्निक्स. ठीक है, तो वी हैव मोस्ट इंटरेस्टिंग थिंग टू रिमेंबर one alphabet. What is that alphabet? You will remember M for Maruti. Remember my name, Dr. Maruti. Okay. Alphabet M. Okay, now once you remember alphabet M, now I will teach you how to understand. Okay, so if you find a M-shaped QRS complex, in V4, V5 and V6. So V4, V5, V6. If you find a M-shaped QRS complex, that is direct indicator of left bundle branch block. So you can look here, M shape. Here also M shape. Here also approximately M shape. So M-shaped QRS complex in V4, V5, V6, especially V5 and V6. You notice here also M shape. Here also if you notice. So if there is a M-shaped this thing is there, then the direct answer is left bundle branch block. So V5 and V6 leads में M shape मिलेगा, तो that is left bundle branch block. Or you can go for one more thing, in the lead to wide QRS complexes. सीधा रट लो इस बात को. अब उतना टाइम नहीं है, कैसा बनता है वो सब समझा सकते हो, बट नॉट एट दिस पॉइंट. सो आप इतना रट लो कि M शेप या वाइड QRS complexes या कहां पे, इन V5, V6 and V4 and also lead to, इनमें से अगर वाइड होता है, everywhere if you notice here in the LBBB, what is happening? M shaped QRS in V4, V5, V6. So because of this M shape, there is a prolongation, or you can say wide QRS. Normally QRS ऐसा होता था ना, QRS very short, मतलब very narrow होता था because of the speed of conduction, but wide QRS बन गया, wide QRS बन गया. Then think of it as a LBBB, left bundle branch block. Okay, okay, समझ में आ गया, समझ में आ गया. चलो let's go to the next case scenario. Again my dear students, कैसा याद करेंगे, क्या करें? अरे सर कंफ्यूज, अरे कंफ्यूज ना हो भाई, मैं हूं ना यहाँ पे समझाने के लिए, मैं हूं. ओके, look here. So when you look here my dear students, what exactly is there? Again M for Maruti, मुझे ही याद करो. ठीक है, तो M shaped QRS, M shaped QRS complex, M shaped कहां पे? QRS complex in V1 and V2, then it is a indicator of right bundle branch block. M shape in, this is your V1, consider this is your V1, V2, V3 is not specific, but V1 and V2, in the V1 and V2, if you have a M shaped QRS complex, blindly the answer is right bundle branch block. So M shaped QRS in the V1 and V2, it is a right bundle branch block. Clear everybody? Clear? So just let me check क्या हो रहा है तुम्हारा. comments continuously मुझे मिल ही नहीं रहे. You're commenting or not also, I'm not able to follow. Just let me close it and open it again. Okay, just let me check. Okay, all good. Okay, so let's continue. Let's continue. What is that? V1, V2, that will be your RBBB. V1, V2, that will be your RBBB. That will be your RBBB. Okay, so that is the story of your, what is that? Story of your right bundle branch block. Okay, let's go to the next ECG. The next ECG, if you notice this ECG my dear students, so if you notice this ECG, if you call this as a P wave, where is Q wave, where is T wave? So if you can't differentiate P wave and T wave, remember superimposed, P and T wave, that is a direct indicator of paroxysmal supraventricular tachycardia, PSVT. What is that? PSVT, superimposed P wave and T wave. You cannot differentiate कौन सी P wave है, कौन सी T wave है. So that will be your PSVT. PSVT will be the diagnosis. PSVT will be the diagnosis. Okay. Again, if you notice here also in this image also, if you notice, so you cannot differentiate P wave to T wave. P wave to T wave differentiate नहीं कर पा रहे हो, and also you are going to have narrow QRS complex. Narrow QRS complexes. So that will be, this will be also PSVT. PSVT के लिए remember the clinical features are going to be palpitation. Clinical features are going to be palpitation. Now this heart rate can vary. In PSVT, heart rate usually up to 200, heart rates. ओके, एंड ये क्या होता है, सडन ऑनसेट, वेरी वेरी सडनली आ जाता है. ऐसा नहीं होगा कि तुम्हें मतलब स्लोली हुआ, ऐसा कुछ नहीं. सडन ऑनसेट ऑफ टेकिकार्डिया विल बी देयर. सो ट्रीटमेंट के अंदर द ड्रग ऑफ चॉइस इज एडिनोसिन. Okay, then if adenosine नहीं होता है, then you can consider calcium channel blocker या propranolol, या beta blocker. But usually first drug is always कौन सी होता है, adenosine. But other things also can be done. Other things what we are going to do in this patient, ये भी ध्यान से सुना करो. ये important चीज क्या होता है, other things what we do in these people are very important. We can go for something called as Valsalva manure. What is it called as? Valsalva manure, to restore the rhythm. Yes, we can do Valsalva manure. We can ask the patient to do Valsalva manure. Recently, there was a viral video on Instagram or Facebook for Valsalva manure and getting the patient heart rate into the heart rhythm into the regularity. Point number one, Valsalva कर सकते हो. Valsalva के अलावा, apart from the Valsalva, we can also go for a carotid massage. कैरोटिड मसाज करने से क्या होता है, मसाज करने से यहाँ पे रिलैक्सेशन की बात नहीं हो रही है. इफ यू मसाज a carotid massage, it will stimulate vagus nerve will decrease the heart rate. That is the purpose of doing a carotid massage. That is the purpose of doing a carotid massage. So PSPT, sudden onset heart rate up to 200. P wave and T wave are superimposed. And most importantly, but the drug of choice is adenosine, Valsalva, and carotid massage can be done. Let's go to the next important aspect, the last two important ECGs. That last two important ECGs, look here my dear students, what I'm trying to tell you people here. So here we have, what is that, all of these are QRS complexes only. QRS complexes only. So you are not able to see no P wave, you are not able to see, or no T wave, you are not able to see P wave also, not able to see the T wave also. But QRS complexes, all of them are in the same shape or different shape. Remember, this is a point, that is your polymorphic QRS. What is that? Polymorphic QRS. Polymorphic QRS. So इसका diagnosis होता है ventricular fibrillation. Sir, what is this scenario? Simple or atrial fibrillation. In atrial fibrillation, atria was doing this dance. In ventricular fibrillation, ventricle does this dance. So ventricle does this dance. All of them records as a Q wave. So if all of them records as a Q wave, ये तो ठीक है. But if ventricle is not contracting properly, blood is not going out, cardiac output can become zero, and person can die very immediately. So that is a problem in the ventricular fibrillation. Okay. So ventricular fibrillation, and we have one more condition here. You look here, you're showing only QRS complexes, but all of them are, what is that, monomorphic. What is that? Monomorphic QRS. Means same shaped QRS. We call it as a ventricular flutter, or also called as the monomorphic ventricular tachycardia. We call it as a ventricular flutter or monomorphic ventricular tachycardia. Monomorphic ventricular tachycardia. In both of these conditions, my dear students, what is the treatment? The treatment is very simple. What is the treatment? The treatment is simple सी बात होती है. The treatment we are going to do, first step is always, my dear students, you are going to do, what is that? Defibrillation. What is that? Defibrillation. The first thing what we can do is defibrillation. The second, then drug of choice, my dear students, according to the latest ACL ALS protocols. मेरा ऊपर लड़ाई करने के लिए मत आइएगा saying that sir पहले लिडोकेन देते थे. भाई लिडोकेन अभी इसका ACLS प्रोटोकॉल से हटा के बहुत टाइम हो चुका है. The drug of choice for ventricular fibrillation is your amiodarone. What is that? Amiodarone. What is the drug of choice for ventricular fibrillation? That is your amiodarone. What is that? Amiodarone will be the drug of choice. First one is always the defibrillation, which is also called as electric cardioversion. Cardioversion. So this is the story of your, what is that? Story of your defibrillation. चलिए आगे बढ़ते हैं. Let's go to the next one. Here, what is this one? अरे ये तो बहुत सिंपल सी बात है यार, बहुत सिंपल सी बात है. यहाँ पे क्या हो क्या रहा है, ठीक है. तो लेट्स लुक एंड अंडरस्टैंड माय डियर स्टूडेंट्स. नॉर्मली देखो क्या है. I'll teach you 1 second. Consider this is the heart, right? Okay. Now in the heart, what exactly I'm trying to explain you people? Every time signal which is generated, it will go to atria, and signal will also go to AV node. Okay. So when signal goes to atria, P wave, and signal will get stuck in the AV node for few seconds, called as AV nodal delay. ठीक है. उसके बाद बनता था QRS complexes. Okay. But instead of that, if I put some alternate pathway to it like this, देखो यहाँ पे ग्रीन कलर से हाईलाइट कर रहा हूँ. So we have something called alternate pathway. We call this alternate pathway as bundle of Kent. ठीक है. बंडल ऑफ केंट. मैं केंट बोलते ही कई लोगों को वाटर प्यूरिफायर याद आया, एंड कई बच्चे जहां जो रशिया से देख रहे हैं उनको कुछ और ब्रांड याद आ गया. ठीक है. सो व्हाट इज दिस? बंडल ऑफ केंट. बंडल ऑफ केंट इज ए एक्स्ट्रा पाथवे. अब क्या होता है देखो, अब क्या होता है, सिग्नल सीधा कहां चले जाता है? वेंट्रिकल में चले जाता है. नाउ हियर देयर इज नो डिले. If there is no delay, my dear student, automatically there is no PQ interval, or there is a decrease of PQ interval. Okay. So decrease of PQ interval. So what is happening here? Look here, P wave. Immediately you are having QRS complex, and here what you are finding this wave, my dear student, called as a delta wave. Delta wave, delta wave. So delta wave, so if you are finding a delta wave, we are finding a delta wave along with that decreased PQ interval, the diagnosis is confirmed WPW syndrome, Wolf Parkinson White syndrome. Delta wave is there, Wolf Parkinson White syndrome. Okay, now this second image Kripal Yadav आपने बताया hyperkalemia. See this second image I have put it just for your comparison to understand. यहाँ पे देखो मैं highlight करता हूँ ऑरेंज कलर या ब्लू कलर से, यहाँ पे देखो पीक इंटरवल तो है ना, यहाँ पे देखो पीक इंटरवल गया, ठीक है, वो समझाने के लिए, वेल दैट इज सजेस्टिव ऑफ कोर्स हाइपरकालेमिया का जैसा ही दिख रहा है, बट आई पुट दिस इमेज फॉर यू टू अंडरस्टैंड द फर्स्ट. Let's go to the next image. Okay, so the next image, my dear students, that is called as Brugada syndrome. What is Brugada syndrome? Brugada syndrome is a channelopathy. It is a channelopathy. What is this channelopathy? Means in the heart we have sodium channels, we have potassium channels, and also we have calcium channel. If there is a defect to the sodium channels, we call it as a Brugada syndrome. We call it as a Brugada syndrome. Okay. So if you look at a Brugada syndrome, my dear students, what exactly you need to understand? Brugada syndrome can be divided into three types. Okay. Now that is Brugada type 1, Brugada type 2, Brugada type 3. Okay. Now, what exactly is this? What exactly is this, my dear students? It's a sodium channel defect. It was found by a group of brothers called as Brugada brothers. Okay. Now, this disease have a sudden onset of death. Sudden onset of death. Okay. So, what exactly we need to remember? We need to remember, my dear students, look at this ST segment, saddleback shaped ST segment that is a direct indicator of Brugada. आपको यूजुअली ये नहीं पूछेगा कि Brugada type 1 क्या है, 2 क्या है, 3 क्या है, उतना डेप्थ में नहीं आएगा. All you need to understand in the ECG, if there is a normally ST segment used to be supposed to be straight like this. ST segment supposed to be straight like this. Instead of that, saddleback shaped. What is that? That is ST segment. If it is there, we call it as a Brugada syndrome. Remember saddle-backed ST segment. Saddle-backed ST segment. If you can't even remember covered ST elevation, that is not a problem for me. I want you to remember saddle-back shaped ST segment and suspected channelopathy, then the answer is Alaikum Assalam. So, what exactly I'm telling you people? What exactly channelopathy is there? So, if there is a channelopathy, then we are going to call it as, very good, we are going to call it as a Brugada syndrome. Okay. So, this is the story of your, what is that? This is the story of your Brugada syndrome. Okay. Let's go to the last part of your CVS revision. This is the most important part. What is that? If there is a myocardial infraction, where exactly you are looking for which thing? Okay. So I want you to remember most two important ECGs. Two important. So if there is a ST elevated MI, if which lead involves, suggest which wall MI. So I want you to remember inferior wall MI and the next one is lateral wall MI. These two I want you to remember. In both of these, in inferior wall MI, 2-3 AVF, in these segments, you will have a ST elevation. ST elevation. Okay. So if ST elevation is found in say lead number 2-3 AVF, then it is a inferior wall MI. Inferior wall MI. It is due to blockage of which coronary artery? Right coronary artery. It is due to blockage of what? Right coronary artery. It is due to blockage of what? Right coronary artery. Which artery? Right coronary artery. Now listen to me. If there is a 2-3 AVF inferior wall MI is there, the most important MCQ is that nitrates, whatever organonitrates blindly we used to give, nitrates are absolutely contraindicated in this case because they will alter the preload very badly. That's why. Okay. For lateral wall MI, lead 1 and AVL, that is the left circumflex artery. But I want you to remember inferior wall MI, most importantly, बहुत फेवरेट हो गया एग्जामिनर का, बहुत बार पूछा भी गया है. Inferior wall MI, if there is a MI, what and all the leads where there will be ST elevation, lead 2, lead 3 AVF, lead 2, lead 3 AVF must be involved. If along with that other leads can also involve, ये बात सुनो, along with that if lead 2 has, ये बात सुनो, if lead 2 has involvement, if lead 2 has ST elevation, automatically you are going to find ST elevation AVF also. AVF also will find ST because they are reciprocal leads. They are what? Reciprocal leads. इसलिए ठीक है, तो mainly 3 leads, 2-3 AVF if they are involved. If others are there for your just confirmation, but I want you to focus on this 3.23 AVF and right coronary artery. Okay, so that is your what is that? That is your myocardial infarction. So this is the story of your myocardial infarction, like the important points related to cardiovascular system. All right. So with this much being said, we'll conclude the live here for today. So I want you to listen to me very carefully. So for your CNS, somebody asked me, sir, neuromedicine क्या पढ़ना है? Go through meningitis. Okay, then next important, Parkinson disease and Alzheimer disease. Okay, in हर चीज में what are the points you need to know? Drug of choice. Okay, then investigation of choice. Okay, then pathological findings. यही चीज को देखो, ठीक है. अल्जाइमर डिसीज, ये सारे जस्ट वन लाइनर जैसा है यार, यू जस्ट ओपन योर नोट्स एंड गो थ्रू दैट. ओके, देन आई इफ यू कैन गो विथ एमएस आल्सो. ओके, एपिलेप्सी का तो ड्रग ऑफ चॉइसेस मैंने ही पढ़ा दिया. एमएस एक बार देख लो, मल्टीपल स्क्लेरोसिस. दीस आर फ्यू वेरी कॉमनली आस्क्ड टॉपिक्स फ्रॉम व्हिच क्वेश्चंस हैव बीन कमिंग. ओके, so this is the story of our, what is that story of our internal medicine rapid revision. All right, hopefully everybody enjoyed it, everybody liked it. See, every place where I have told this is important, ये ECGs के अंदर, if they ask a ECG question, there will be definitely one ECG from these ECGs only. Okay, चलिए, thank you so much, and I will share your notes as soon as possible, and previously whatever notes you had asked which have been already uploaded, so that is also done. Okay, सर्जरी का यार, सर्जरी का मैं ऐसा नहीं बोलूंगा क्योंकि मेडिसिन अलग है, सर्जरी अलग है. सर्जरी इज ए सब्जेक्ट वेयर फ्रॉम द फिक्स्ड नोट्स ओनली क्वेश्चंस आते हैं, ठीक है. ऐसा मत किया करो. सर्जरी के अंदर भी अगर आप लोगों को करना है तो ऐसा मतलब इंपॉर्टेंट टॉपिक्स देखना है तो यूरोलॉजी, जनरल सर्जरी तो कैसे भी कर लिए होंगे, तो यूरोलॉजी एंड वास्कुलर सर्जरी अच्छे से करो, क्योंकि तुम लोगों को सबको दो चीज अच्छा है, ठीक है. अरे नोट्स वो इन द डिस्क्रिप्शन ऑफ द वीडियो देयर इज ए लिंक, वो लिंक खोल के देख लो, आपको मिल जाएगा, ठीक है, आपको मिल जाएगा, ठीक है जी. तो व्हाट आई एम ट्राइंग टू टेल यू पीपल, सुनो. तो दूसरी एक है कि यूरोलॉजी एक है, वास्कुलर सर्जरी एक है. तो ये दोनों में से क्या होता है, ये दोनों में मतलब यू हैव स्टडीड जनरल सर्जरी एंड जीआईटी तो बहुत अच्छे से कर लिए होंगे, बट ये दोनों छोड़ देते हो. ये दोनों बहुत टाइम नहीं लगेगा, एक सुपरफिशियल ग्लांस करो फिर भी काम चल जाएगा. एक सुपरफिशियल ग्लांस भी करो, तुम्हारा काम चल जाएगा. बहुत इंपॉर्टेंट चीज है, ठीक है. All right. So with this much being said, we'll conclude our live here with this. And thank you so much. Hope all of you like the questions and discussion which we did. And I would request you people to go through these topics at least, very importantly, 3 to 4 topics at least. Okay. And right now we have 2 दिन है तुम्हारे पास. 2 दिन के अंदर डरो मत. आप डरोगे तो भी एग्जाम जाना है, नहीं डरोगे तो भी एग्जाम जाना है, ठीक है. ऐसा कोई तुम्हारे पास कोई बड़ा ऑप्शन नहीं है, ठीक है. सो इसलिए मैं पहले से ही बोल रहा हूँ, कोई दिक्कत नहीं, पूरा दम के साथ जाओ, ठीक है. मैं जैसा आइडिया दिया था वैसे ही करो. एग्जाम के दिन सुबह थोड़ा बहुत बायोकेम देख ली, थोड़ा बहुत पैथ हेमेटोलॉजी देख लिया, पिछले दिन ओबीजी पीएसएम, ठीक है, तुम्हारा सर्जरी कर ली. ब्रेक में, दोनों एग्जाम का ब्रेक में पेपर टू का इमेजेस कर लो, ठीक है. देन वन डे बिफोर दैट डू द अदर सब्जेक्ट्स, ठीक है. बट इतना ही करो, पूरा नोट्स बैठ के पढ़ना नहीं. what you are supposed to do is that कि तुम पहले से ही नोट करके रखे होंगे यार, ये क्लास, ये सब्जेक्ट में ना ये एक टॉपिक मुझे हमेशा कंफ्यूज होता है, लास्ट में एक बार देखना है मुझे. So in this topic or in this subject, I have one topic which always confuses me. I must go through this once before the exam. You might have kept that topic. So go through only those topics. That is the important thing which will help. ठीक है. एंड नींद कर लो भाई, प्लीज. आई रिक्वेस्ट यू पीपल, आई हैव बीन टेलिंग मेनी प्लेसेस, एवरीवेयर आई टेल यू, नींद अच्छे से कर लो. अच्छे से मतलब मैं ये नहीं बोल रहा हूँ कि 12 घंटे सो जाओ. एटलीस्ट 5 to 6 आवर्स ऑफ स्लीप, 5 to 6 आवर्स बिफोर द एग्जाम चाहिए ही चाहिए. आप बोलोगे सर नींद नहीं आएगा, नींद नहीं आएगा, one day before the exam, if you don't get sleep, just lie down, close your eyes, don't do anything, कोई दिक्कत नहीं। कल सुबह एग्जाम है, आज रात 10-11 बजे तक हम लोग लेट गए तो फिर हम कुछ नहीं करेंगे, बस ऐसे ही लेटे रहो, कोई दिक्कत नहीं। नींद नहीं आएगा, कोई दिक्कत नहीं, बट लेटे रहो। जस्ट क्लोज योर आइज एंड लाई डाउन एंड गिव योर बॉडी सम रिलैक्सेशन एंड गेट सम गुड फूड। बिना like without food, without proper food and normal basic sleep in the last 2 days, how much ever you do, it will pressurize your brain. Don't do that mistake. Have some decent enough amount of food, because without food, glucose niyat, bis glucose nichyo without glucose nothing will go into the brain. That's why I'm telling you. Okay, all right. So hope you'll follow all these things. See you people tomorrow with pediatrics division. Thank you so much. Bye bye.